I think we're going to start now, as soon as I find my glasses. Thank you. There are so few people in the room that perhaps we could make it a little warmer and cozier by your coming forward and sitting closer to the front. If you'd like to, then we can have a small group session. The session is on cancer prevention, the topic of behavior, and I'll give you an informal introduction of myself. My name is Ellen Gritz. I'm the chair of the Department of Behavioral Science at the University of Texas MD Anderson Cancer Center, and I hold the Ola S. Stribling Distinguished Chair in Cancer Research. My interest in head and neck cancer began in the 1980s when I was at UCLA and I was conducting smoking cessation research with head and neck cancer patients. I was a professor in the Department of Head and Neck Surgery at the time, and I conducted the first randomized trial of a smoking cessation intervention in head and neck cancer patients. In that trial, we had an extraordinary, biologically validated, over 60% continuous abstinence rate of smoking cessation in head and neck cancer patients who were treated with an intensive regimen of physician advice and maxillofacial prosthodontist advice, supported by written materials, telephone calls, and follow-ups over a 6-month period. To this day, no study has replicated such high abstinence rates, biologically validated. And I will invite us to consider over the course of this session what may have led to changes in smoking and quitting behavior in head and neck cancer patients. One of my hypotheses is that until the trial I conducted, physicians were not emphasizing the importance of cessation to their patients, so many patients continue to smoke. And now physicians routinely do that, so there may be much higher spontaneous quit rates at the time of diagnosis and beginning of treatment. So that's an interesting secular change over time, but we're going to have some wonderful data today with regard to nicotine dependence, body image, multiple substance use, and outreach in head and neck cancer. And I will introduce now our first speaker, Dr. Robbie Schnoll. Dr. Schnoll is an assistant professor at the Transdisciplinary Tobacco Use Research Center in the Department of Psychiatry at the University of Pennsylvania, where he directs an independent and collaborative research program designed to evaluate methods for improving treatments for tobacco dependence. After receiving his PhD in psychology from the University of Rhode Island in 1998, Dr. Schnoll completed a postdoctoral fellowship in cancer prevention and control at Fox Chase Cancer Center and remained there as a faculty member in the Division of Population Science until September 2005, where he moved to his current position at the University of Pennsylvania. Dr. Schnoll's research focuses on the study of new methods for treating tobacco dependence, the examination of novel ways to use existing treatments for tobacco dependence to improve their efficacy, and the study of issues relevant to smoking cessation clinical trials. Dr. Schnoll has conducted behavioral, physician-based, and pharmacological clinical trials for smoking cessation among cancer patients. We're beginning a bit late, but every speaker will have 15 minutes, and I believe we will have enough time for questions from the audience. So may I invite Dr. Schnoll.
Thank you very much, Ellen. It's a pleasure to be here. I want to thank the conference for inviting me to speak today and talk a little bit about the work I've been doing with cancer patients. So I'd like to start off many of these talks by emphasizing two main points. The first being that smoking among cancer patients is still a significant clinical problem, and here you see some epidemiologic data collected and summarized across a number of different tumor types and compared to the prevalence in the U.S. today and in Pennsylvania, my home state. And you can see that head and neck cancer is certainly a significant problem in terms of continued tobacco use, with about a third of patients continuing to use tobacco after their diagnosis. And the second major point I'd like to make in talks like this is that the consequences of continued smoking among cancer patients is an important one. There is accumulated data from a number of different studies that show that continued tobacco use is associated with shortened survival duration, an increased risk of a recurrence or a second primary tumor, reduced treatment efficacy, and an increase in symptoms and lower quality of life. So we've conducted a few different clinical trials looking at smoking cessation interventions for cancer patients. The first clinical trial I was involved with looked at a very minimal intervention where we trained physicians to provide smoking cessation advice and assistance, and this study was conducted in several different cooperative groups and at Fox Chase Cancer Center. So we recruited cancer patients and physicians into this study. You see the eligibility criteria, and we randomized 432 cancer patients across a number of different disease sites to either a 5A's intervention. The 5A's is sort of shown on the left here, where physicians were trained in helping patients set a quit date, provide systematic quit advice, discuss and provide NRT as appropriate, provide self-help material and a referral to the Cancer Information Service, and continually assess progress as patients continued to come in clinically. They either received training in that model or provided usual care, and we conducted follow-ups at 6 and 12 months post the provision of quit advice. Unfortunately, we didn't find that training physicians yielded a significant increase in cessation either at 6 months or at 12 months, shown here in terms of 7-day point prevalence. So we concluded that we needed to provide something somewhat more intensive to cancer patients to promote cessation. So we started with a small study with just lung and head and neck cancer patients at Fox Chase Cancer Center. We approached 231 patients, 109 agreed to enroll and were randomized to either a tailored cognitive behavioral therapy in addition to quit advice and NRT, or the standard cessation counseling program that's based on standard treatment guidelines. And we had 102 patients that declined this intervention, and I'll come back to talking about them in a moment. We had tailored, the tailored intervention was based on some earlier work that we had done where we followed cancer patients over time and looked at longitudinal predictors of the ability to quit smoking or the decision to continue to smoke. And we found that a number of different psychological characteristics in terms of emotional distress and confidence to quit smoking, the perception of the advantages or disadvantages of quitting, perceptions of risk, fatalistic attitudes, and level of nicotine dependence were strongly correlated in terms of differentiating between smokers and quitters. So we had based our tailored intervention to address these specific psychological characteristics. Again, unfortunately, when we looked at our 30-day point prevalence a month and 3 months after a designated quit day, we did not see any significant difference in terms of cessation rates between the standard smoking cessation counseling approach, which included NRT and physician advice, or our tailored approach. Now, remember I said that we had a number of patients that refused to enroll in our trial, and we decided to study these patients in terms of data that we had collected in the screening process and that were clinically available to us. The consequences of poor enrollment rate are that it could threaten internal validity, threaten external validity, and it reduces the clinical impact and relevance of our intervention by potentially failing to treat patients that are most in need. So we decided that with the data that we had available to determine the rate of refusal of cancer patients to enroll in our clinical trial and to look at differences in data that we had available in terms of demographic, medical, and smoking-related characteristics. And these were the results of the comparison between enrollers and decliners. We found in our logistic regression model that head and neck cancer patients were more likely to be decliners. Decliners were more likely to have fewer symptoms of their disease, had lower intention to quit, and smoked fewer cigarettes. So we thought maybe that in terms of motivating patients to enroll in our trials, we needed to target interventions to those patients who thought perhaps that they were not at increased risk of the negative health consequences of continuing to smoke. So we also concluded that we needed to address smoking nicotine dependence with a more intensive intervention. We found that basic quit advice and tailored counseling plus NRT were not adequate in terms of sort of basic approaches. We also knew from our descriptive longitudinal data that depression was a barrier to successful cessation for us, and was also has been found consistently to be the same in the general population. We also know from a wealth of data that a substantial number of cancer patients exhibit clinically relevant levels of depressive symptoms, and we also know that there's an antidepressant, bupropion, that has been effectively demonstrated to be a treatment for nicotine dependence. So based on those lines of research, we want to address the primary question of whether or not an antidepressant, bupropion, was an effective treatment for depressed smokers. And when I was writing this study, I was greatly influenced by the work of Brian Hitzman, a colleague of mine, who had conducted a study where the results are shown here. This was a fluoxetine study where they conducted it was not with cancer patients, it was a placebo-controlled trial of fluoxetine for smoking cessation. They found no effect of fluoxetine, but when they looked at the depression score in terms of the log odds ratios, you can see that that's when they started to see a separation of the likelihood of cessation 1 month after treatment for those who were treated with fluoxetine, suggesting that there's an interaction effect between depressive symptoms and an antidepressant for smoking cessation. So we just finished this trial. We finished our initial follow-up in June, so just a couple of weeks ago. And here you see the design of the study where we are recruiting cancer patients, and we stratify by their score on the Center for Epidemiologic Studies depression scale, and 16 or above is depressed. And then we randomize to bupropion or placebo, and everyone gets the patch in behavioral counseling, and we're doing follow-ups up to 1 year post-quit date. Here you see our accrual for the study. We have conducted a great deal of screening. Over 7,000 phone screens were conducted. From this, 291 patients were brought into our clinic and given a history and physical. 246 were stratified and randomized, and here you see the 4 study conditions and the dropout rate, which was fairly low compared to other similar clinical trials. And here you see our intent to treat sample, of our 246 patients across the various conditions. We do find a difference in gender and in education, and as you'll see in a minute, in our major model, we are controlling for these characteristics. So here is, this is very fresh data. As I said, we just finished, this is the week 12, 7-day point prevalence, biochemically confirmed quit rate, stratified across our 2 groups, depression and non-depressed. And you can see the interaction effect is significant here, showing that among non-depressed patients, there is a non-significant difference for quit rates between placebo and Zyban, but there is a 2-fold increase in cessation among the depressed patients who are given bupropion. And we're also starting to look at the changes clinically in terms of symptoms among those who are quitting smoking, and we're seeing here a trend. This is a checklist of symptoms, for example, shortness of breath, scored on a scale from 1 to 5. You have the smokers in the yellow, and those who are quitting who have quit at week 12, biochemically confirmed, showing a reduction in their physical symptoms. So I want to just quickly mention some of the new work that we're doing in this area, and we're broadening our work to include family members of cancer patients by looking at a study of the teachable moment for smoking cessation. So a teachable moment, for those of you who are unfamiliar, are events or transitions in our life that inspire us to enact health behavior change when we otherwise may not be. And this is with minimal or no formal professional intervention. So these are regular physician checkups, early detection screening feedback, pregnancy, and hospitalization or diagnosis of disease. This concept is used to guide interventions regularly to promote dietary change, exercise screening, smoking cessation, but there's, in my view, a lack of evidence that a teachable moment exists. The shortcomings of the teachable moment literature in terms of methodology, there's been no study that's used a matched comparison group that's not experiencing a cueing event or the teachable moment. Studies are cross-sectional with a single assessment post-cueing event, and studies have not incorporated biochemical verification of smoking cessation. There are a number of conceptual shortcomings as well, including a lack of assessment of a theoretical model of teachable moments, a lack of assessment of moderators, so who may be more affected by a cueing event versus not, and a lack of assessment of the impact of a teachable moment on those indirectly affected using a more primary prevention approach. Whoops. So the aims of this study are to compare smokers who are relatives of cancer patients to smokers who are relatives of orthopedic patients as our matched comparison group in terms of willingness to enroll in a smoking cessation program and their response to the program in terms of cessation. We're exploring a heuristic of teachable moment, specifically involving perceptions of personal risk and outcome expectancies, effective responses to the cueing event, and how this cueing event may redefine one's self-concept and social role. And we're exploring characteristics that may moderate the impact of a cueing event on individual behavior, such as closeness between the patient and the family, the disease severity, and how someone generally copes with stressful life events. And this is our study design, where over the next 4.5 years, we're recruiting 375 smokers. Half of these will be relatives of cancer patients, half of them relatives of orthopedic patients, and we will invite them into a free smoking cessation program involving NRT and phone counseling. The rate at which patients across the two groups agree to enroll in our study is the first outcome measure of this study, and then their response to this intervention is the second outcome, hopefully demonstrating that cancer relatives are more willing to enroll and more responsive to a smoking cessation program because they're experiencing a cueing event or a teachable moment. So with that, I'd just like to list the numerous people that are involved in these studies across the University of Pennsylvania and at my old institution, Fox Chase Cancer Center, and thank you very much for your attention. Our study chair has indicated that we can accept questions now rather than at the end. So,
I've got a question if nobody else does. I'm curious, the quit rates in your head and neck study are at week 12, right?
Yeah.
And it seems relatively low. And I was wondering how intensive the counseling was and what other hypotheses you might have about that would account for that. This difference between the non-depressed and the depressed, of course, is quite striking. And the second question is, in your new study, I was interested that you chose to use NRT and not bupropion or varenicline. I wondered what the rationale for those were.
Sure. So the first question had to do with the quit rates at week 12 here, which I can't recall what they are across the entire study. They're probably in the neighborhood of 25% or so. A lot of this, Ellen, is being driven by depression. We do have a main effect for depression here, and as we see in a number of different studies, this is current depression, this is not just history of depression, but that is serving as a very strong barrier to cessation.
Do you know whether there was a high spontaneous quit rate? Because my concern or my interest in what has happened over time, between when I conducted my study and the presence.
Yeah, that actually shows up here, Alan. When you look at this 7,000 phone screens and this 5,800 that people are ineligible, that's where you're seeing the spontaneous
It's really
cessation.
important. Really
yeah,
important.
So that's where you're seeing a great. That's why it's so challenging to recruit for these studies, is because you have so many patients that as soon as they're diagnosed, they quit smoking. And then the second question had to do with why aren't we using varenicline here in this study, and that's because when I submitted the grant, varenicline wasn't FDA approved.
Okay, great.
And unfortunately or fortunately, it was funded the first time in, and we didn't have a chance to revise our budget.
He's crying about being funded on the first submission. There's another question over there.
Yes. Yeah. 25%. Scored 16 or above on the CESD. They were newly diagnosed, so within the first few months of diagnosis. That's another reason why it was very hard to accrue for this study. Yeah. Sure. Sure. We decided for two reasons to do that. First, theoretically, we were interested in showing that the concept of a teachable moment could be applicable to primary prevention, to preventing someone from developing the disease initially. And so looking at preventing secondary cancers or improving quality of life among cancer patients was just not the focus of this particular study. That would be more of secondary or tertiary prevention. And secondly, I've spent probably 7 years or so recruiting cancer patients for clinical trials, and I'm sure, Ellen, you could agree with this. It is very difficult to do, and I was interested in extending beyond the narrow population to include those relatives as well, and I think that was just an underutilized, sort of understudied population as well.
Okay, I think we're going to hold now until the end, but hold your thought. Thank you so much, Robbie, for an excellent presentation. Our next speaker is Dr. Michelle Corot-Fingaret. She is an assistant professor in the Department of Behavioral Science with joint appointments in the departments of plastic surgery and head and neck surgery at the University of Texas MD Anderson Cancer Center. Dr. Fingaret is a licensed psychologist and has specialized interests in body image, smoking cessation, and psychosocial oncology. She recently completed an NCI R25 Cancer Prevention Fellowship to prospectively examine the relationship between body image, smoking behaviors, and quality of life among newly diagnosed patients with oral cavity cancer. Her current work involves evaluating the nature and extent of body image concerns in different cancer populations, identifying risk factors associated with poor psychological adjustment to alterations in body image, and developing psychotherapeutic interventions to alleviate body image suffering in the oncology setting. She is also interested in developing body image-focused treatment components to promote smoking cessation and reduce relapse rates. In addition to her work in the oncology setting, Dr. Fingaret is currently co-investigator on a 5-year NCI-funded R01 grant, which I'm the PI of actually, designed to assess the efficacy of a cell phone-delivered smoking cessation intervention targeted to persons living with HIV/AIDS. Michelle?
Thank you so much. I'm going to be talking more specifically about my work in the area of body image and less focusing on smoking outcomes because that's going to be covered by some of our other speakers today. But body image is an important psychosocial issue for head and neck patients that is often neglected. And to think about it just in terms of cancer prevention and control, there's obvious implications for cancer control. In terms of prevention, I really think about it more from helping to prevent the acute psychosocial distress that can arise if we can address these issues with patients in the clinic. So what I want to focus on, I'm going to check my time so I can stay within the time limit here, is really presenting a model that talks about multiple dimensions of body image because it's a very complex and rich construct. It's not just about how one views themselves. And I want to talk about that model and how body image can influence psychosocial functioning in head and neck patients. I'm going to focus briefly on some associations between smoking behaviors and body image because that's obviously relevant for this patient group. And then I'm going to talk a little bit about treatment in this area. So to give you all a taste of the large body image literature that's available, really focuses on body images being very multifaceted. It's not just about how one views themselves or their appearance. It can encompass perceptions, thoughts, and emotions about a range of body experiences that happen to people. So we want to consider that it's not just about appearance, but also about bodily functioning and bodily sensations. All of those are within the realm of body image for the cancer patient. What's really also important is to note that this is a very subjective concept for patients. We want to understand the patient's experiences, not so much objectively what the physician sees or how you can measure different symptoms, but what is the patient's experience. We know from the literature in the area of disfigurement, for example, facial disfigurement, that there is no correlation between the degree of somebody's disfigurement and their adjustment to it. There's a lot of individual factors that go into what one's adjustment is eventually going to be. We know that patients who have large defects, some of whom adjust quite well, some of whom adjust very poorly, and then there are also patients who have very small defects who may have very difficult times adjusting. So we need to understand what some of those individual factors are that affect adjustment. And then the last part is to really understand that body image is very dynamic. It can be affected by contextual factors, environmental factors, and obviously a lot of individual factors. So it's affected by experiences of the moment and can change based on disease progression, based on treatment. It's something that we need to continually assess in our patients. So as I've said, there's a number of different components of body image. We want to think, I can describe some of the cognitive aspects just in terms of how a patient is thinking about their own appearance or their own bodily changes in terms of functioning or sensation. Some of the behavioral aspects that have been studied are things like excessive grooming rituals, patients who are very hyper-focused on the way that they look, as well as avoidance of social activities. Sexual behaviors can go into this category as well. And even though right now I'm focusing on patients that are having a very difficult time adjusting, we know that body image changes and difficulties with body image are very normal for a cancer patient. So I am going to present a model that talks about this not only in a pathological sense. Over here on the other side are a lot of different concepts that have been talked about in the literature. I'm not going to go through all of these. One of the ones that I focus a lot in my area of research is on investment. So the degree to which a patient is invested in their appearance. That obviously is going to be a big driving factor in terms of what their adjustment. The more invested they are in how they look, the types of changes they experience, they might have more difficulty adjusting. Bodily integrity is important to think about because that is defined as how one values their body as a functional entity. So that obviously is compromised in head and neck cancer treatment. On the bottom, we can think about body image from a totally different perspective, which is thinking about it more in terms of positive adaptation to body image changes. Many patients become quite resilient to the body image challenges that they face. And there's also a concept called post-traumatic psychological growth, which really refers to thinking about these changes as being a blessing in disguise. So you may have patients who wear their scar as a badge of honor, that they're a cancer survivor, and they're very proud of that. And they don't have poor adjustment. They actually have good adjustment. We need to understand these patients as well because they can teach us a lot. So there's a few things here that I really want to highlight, and it's understanding that patients come into treatment with a whole history of body image issues and psychosocial functioning, and it's something that's very important for us to understand. We also want to look at the expectations that patients have for what types of bodily changes they can expect based on their disease and treatment. Because the research has shown, there's been a lot of research by Dropkin and colleagues looking at how patients who have unrealistic expectations of scarring or other functional changes are the ones that have the most difficulty adjusting. It doesn't have to do, again, with the severity or the size of the defect or the types of issues that they're having. It's what did they expect when they came into the clinic. And this has a lot of implications for treatment because it means we need to focus a lot of our effort and energy on educating patients for what to expect. Another thing to keep in mind here is obviously looking at the degree to which the changes they're experiencing are gradual versus rapid. So this has a lot to do with the nature of the disease, the site, the type of tumor, the type of treatment. And then, of course, going beyond just appearance, we need to look at the functional changes, the sensory changes, and also how external devices can affect people's body image. I want to point out a few things here that it's important to note that the bodily changes that people experience can act as persistent reminders of the disease, and to know that we're not only talking about observable effects. Again, this goes to the heart of patients' subjective experiences. It doesn't matter whether it's observable or whether it's something that can be measured. It's all about how the patient experiences it and how they can relate that to the healthcare team. So this just gives you an example. This is not exhaustive, but of a lot of different types of cancer-related body image concerns that can be tied to head and neck. And as you can see, some of these are really involving appearance, so scarring and disfigurement or swelling or weight changes. But there's a whole host of body image concerns that involve functional and other aspects. So this just kind of gives you, I think, a very broad picture of just how many different aspects of functioning we're talking about here. So I would be remiss if I didn't mention something about the relationship between body image and smoking. I obviously focus some of my research in this area, and part of this is to understand, going back to the idea that people come into treatment with a whole history of their own body image. We know that in the general population, there's a lot of research showing that there's an association between weight concerns and smoking behaviors, largely for women. So weight concerns can be associated with initiation, maintenance, and relapse in smoking. So this is not to say that for the head and neck patient, we're going to be focusing so much on how concerned they are about their weight, because there's obviously other disease and treatment-related aspects of body image changes we're focused on. But to understand that people who come into treatment who've had a whole history of having weight concerns and being focused on their appearance, if they continue to smoke and they already are predisposed to having these issues with body image, if they have surgical treatment, for example, there's an increased risk for wound infection and wound healing, which places them at greater risk for facial disfigurement. So they may have a much more difficult time adjusting to these issues than patients who don't smoke and patients who aren't coming in with a history of these weight concerns. And on another note is to understand that smoking can decrease the treatment effectiveness of lots of different types of treatment modalities and can exacerbate many of the functional and sensory side effects of some of the treatments. So this is the slide that I really would like to focus a bit of time on, because this is a conceptualization of body image that I think is really important for the cancer patient. This model really just refers to the appearance-related aspects of body image, because as a psychologist, I don't deal in rehabilitation of functional aspects. I really focus on helping patients adjust and cope to the appearance-related changes that they have. It's not at all useful in the oncology setting to think of body image disturbance as being pathological, because every patient is going to experience bodily changes. So therefore, we expect that the majority of patients will have some degree of body image concerns. It's normative to have these body image concerns, and that's something we need to focus on when we educate patients. Now, we do have a group of patients over here on the left who may report no body image concerns whatsoever, and it may be that these patients are genuinely not concerned about or invested in their appearance. I've seen 60-year-old men who've told me, I was ugly before my treatment, I'm going to be ugly after. It's just not something that is on their radar whatsoever. What's of bigger concern, though, are the patients who may minimize their body image concerns or be reluctant to talk to their healthcare provider about their body image concerns because they don't feel that's something they're supposed to be focusing on. They feel they're just supposed to be grateful that they're surviving, and it's not something they want to burden their provider with. And those are the patients that we need to try to draw and understand more about. And then there's going to be another group within this subgroup of patients who have very positive adaptation to the changes. It's something that, again, goes back to that concept of post-traumatic psychological growth. On the other end of this spectrum, these patients we are highly concerned about because their body image concerns are interfering with their functioning to the point where they can't work, they can't get out of bed, they can't go about doing normal activities that they functionally should be able to do because they're so concerned about how they look and the body changes that have happened to them. These are the patients that may experience clinical levels of depression, anxiety, maybe have suicidal ideation, and we need to think about different interventions that can be applied. I would argue that you can apply interventions across this whole range of the continuum for patients to help them adjust to the body image changes. So what do we do? Where do we go from here? We need to understand how to assess body image in the clinical setting, and this could involve very screening procedures that just help, first of all, provide healthcare providers with a way to initiate body image concerns. One suggestion would be the distress thermometer that's becoming more and more popular now, which is just a scale from 1 to 10 to ask patients how distressed they are in that moment. Along with that, you'd have a list of problems that patients are experiencing that may be related to their distress. We should include body image in this, especially for head and neck patients. It also can give us a way of tracking body image concerns over time with our patients, because this should ideally be done each time they come into the clinic. In terms of treatment, obviously, the goal is to help prevent the body image disturbance from arising and affecting functioning and affecting quality of life. So on the front end of it, we really need to focus a lot on education. We can do things to help patients manage the concerns that they're having in their head, the way they're thinking about the body image changes, helping manage their expectations, doing some behavioral modifications to help anticipate what types of reactions they might have and help them be more comfortable in social settings and in communicating with people. And from the treatment side of things, this really is just intensifying the cognitive behavioral approaches and using maybe physical interventions, and something new on the scene are these mindfulness and acceptance-based approaches. And that really just helps patient be more present, living in the moment, and figuring out ways to value and enhance their current lives. So a model that we're working to implement at MD Anderson is trying to integrate psychosocial services into specialty healthcare. That's having a psychologist or mental health professional in the clinic who can be there to help alleviate some of the diagnostic and treatment-related distress about coping with appearance changes. So some of the treatment components here would include obviously a heavy focus on education, and then some of these other techniques, problem solving or communication skills training, which can help not only the communication between the patient and their family, but also maybe communication between the patient and their healthcare provider. And by having an in-house person who can help work with patients, and this would be a brief model, 1 or 2 sessions, and then as needed after that, it can help improve the recognition of psychosocial needs and behavioral health needs of patients. And you're going to be enhancing collaborative care and having an internal resource so you don't have to always refer out to specialty mental health care, more intensive mental health care when you need it, but you have somebody there who might be able to manage the patients who aren't on that severe end of the spectrum. Because there are going to be times where you are going to have to refer to the psychiatric services. But you'd be able to have rapid feedback to providers and prevent, obviously the goal here is to prevent more serious behavioral and psychosocial problems through early recognition intervention. So to wrap up and to talk about some future directions here, I didn't really mention this, but assessment tools, it's very lacking in the area of body image. We need to do a lot more research to improve and refine the assessment tools. We want to be able to determine how to detect clinically significant issues with body image, that we know where to target our treatments, and we need to also do a lot more work to look at the nature and extent of body image concerns in different patient populations. One area that I think is particularly interesting is to look at the influence of body image concerns on treatment decision making, especially for patients who are declining treatment. Are patients declining treatment because they're having so many concerns, not only about the appearance-related changes that they're going to experience, but also the functional changes? And along with that, we might be able to design body image focused intervention treatment components that can aid in smoking cessation for cancer patients. Thank you. Any questions?
Question, I just have a comment. That was an excellent presentation. I think it's very forward. It's very forward-thinking, and certainly had patients who made treatment decisions based on concerns for appearance and functional considerations and decline treatment. It's very sad when that happens, or they kind of talk. We see a lot of patients with recurrent disease that talk their local doctor into doing, the good doctor was the one that would do less and preserve their branch of their facial nerve or not make a cut on their face, and then they come and they realize that there's things worse than that. So I think it's critically important. We're lucky to have you to interface with our patients at MD Anderson, but I think hopefully this will be something that other people recognize and do at their own institutions through the presentation. The other one that I thought was interesting, this is the first time it happened to me, but about 2 weeks I was in clinic and I'd operated on someone, had done a neck dissection, and the patient unfortunately had a problem with wound breakdown and now has kind of an ugly scar, and he's a young guy, and I keep telling him, we'll get you to plastics and they'll revise the scar. And he said, well, earlier this week I was on a TV show and there were these young girls, he has melanoma, so these young girls were there and he was able to kind of talk them out of tanning and sunbathing because of this scar, and it made such a visual impact on them that he was kind of proud that he was able to make a positive influence through this experience on others.
Interesting.
Thank you.
The last question.
Brandon Bentz from the University of Utah. It's an excellent area to address in this time. I think that it's absolutely important for us to start looking into the psychosocial aspects of what we do to our patients. My question is, in measurement of the impact that we do with psychological counseling and social counseling, are you aware of, or have you thought about what biomarkers we can use to evaluate what the impact is upon our patients?
That's an excellent question. Obviously, one that speaks to the need for multidisciplinary treatment teams to work together and research teams to work together. I personally can't comment on that and would look to my colleagues at MD Anderson who are experts in that area to help me focus on that. But I think if we're going to get funding for things in this area, that's something that would be critical to consider. Thank you.
Thanks for a terrific presentation, Michelle. Our third speaker is Dr. Sonia Duffy. She is an associate professor at the University of Michigan, School of Nursing and Departments of Otolaryngology and Psychiatry, and the VA Ann Arbor healthcare system. Dr. Duffy was educated in health behavior and epidemiology. Since then, her research interests have focused on the association of health behaviors, including smoking, alcohol use, sleep and depression, and quality of life, recurrence and survival, particularly among head and neck cancer patients. As a means of more efficient delivery of healthcare services for both patients and providers, Dr. Duffy is interested in multifaceted cancer-related interventions that can be administered in combination. For example, combined smoking, alcohol, and depression interventions, as opposed to one-dimensional programmatic approaches to changing health behaviors. Sonia.
Hello, everyone, and welcome. This is a Michigan story of one of the projects from our SPORE grant, where we were kind of forced by the NCI, who is very smart in some ways, to work people to force people to work in multidisciplinary teams. And I am convinced, although I wasn't initially convinced, that it is the way to go. So I'm going to tell you a little bit about the Michigan story. I have nothing to disclose. There are many, many people, only a few of which are mentioned here, that have contributed to this project. And the specific aim here was to determine if health behaviors, comorbidities, and molecular markers are major predictors of recurrence and survival and quality of life among head and neck cancer patients. And the way we kind of came to this question was the NCI kind of forced us to get in a room together and talk. And I was saying, we really need to do more with the health behaviors. That's the way to go. And the clinicians were saying we really need to do more with treatments. That's really the way to go. And the basic scientists were saying is we really need to find new molecular targets so we can find new chemotherapeutic agents or whatever. And so the truth was nobody really knew where the best place to put our resources were. And the fact of the matter is that survival rates have not changed much in the last 20, 30 years for head and neck cancer patients. Yet 40% do survive. So the question in my mind is, who survives? What are the differences between those who make it and those who don't? And if we could figure that out, then we might know where to put our energy into improving survival for this population. This was a longitudinal study. We have about 811 patients recruited into the study. We are looking at their health behaviors. We are looking at smoking and alcohol, which was one of my major interests. But we did add diet, physical activity, and also sleep questionnaires. We also look at their comorbidities and depression. We look at some molecular markers, P53, which is a gene mutation. That is the gene that mutates in response to smoking and also to sun exposure, actually. And then human papillomavirus, which is the new virus, not necessarily new, but kind of epidemic coming up in head and neck cancer patients, and VEGF, which is vascular endothelial growth factor, which is a marker that looks at how quickly a tumor can establish a blood supply. Our outcomes were, as I said, quality of life, recurrence, and survival, and then we also had some control variables, demographics, site and stage, and treatment characteristics. So we really do have a wide variety of variables that we're looking at in this longitudinal study, and you can really see the influence of the multidisciplinary team on the types of things that we're looking at. We have self-administered questionnaires that we give to patients. We have lengthy questionnaires at 1 year, 2 year, all the way up to 5 years. We have mini questionnaires at 3 months, 6 months, 9 months in the first year, because of that teachable moment where we'd like to look at some changes in health behaviors occurring during the time when cancer patients are pretty stressed out. We do blood draws every 3 months for the first 2 years, so we have the opportunity to look at markers, and we also gather tissue and send it to our tissue core when we can, although tissue specimens can be small in head and neck cancer patients and oftentimes used for diagnostic purposes, but when we can, we get tissue. Let's see. So in terms of our recruitment, most of our cancer patients come from the University of Michigan. We make huge efforts to recruit minorities into our study. We go to Henry Ford Hospital in Detroit and also to the VA hospital, which is down the street. And we have 85% white, about 15% minorities with that extra effort. Had we not gone to those 2 other sites, we'd probably have 4% minorities. So I just want to, and we do have a much higher refusal rate among minorities, so just a little bit of a story about how hard it is to get minorities recruited into studies. You see a little bit about the demographics of the population. Pretty typical. About 59, 60 years old, about half of them have a high school education or less, and 3/4 male. Again, some clinical characteristics. We see about 1/4 larynx and about 1/4 oral and about 50% pharynx. This breakdown has actually changed over the 5 years. When we first started out collecting data 10 years ago amongst head and neck cancer patients, we saw about a 1/3 split in those areas, and I do believe that the change is due to the HPV positive tumors that we are seeing, and most of our increases in that pharyngeal category are tonsil cancers, which are common in the HPV positive cancers. Most of our cancers are stage 4. We are a tertiary care facility. Many people come to us for second opinions from places far away. And you see a little bit about our comorbidity scores. We use the ACE comorbidity score, and that just gives you a little bit of that profile. So you see that 213 of these 811 have recurred and 254 have died. This gives you, kind of hard to see, but it gives you a little bit of a profile of what happens in the first year after diagnosis of the health behaviors. You see that about half of the patients quit without any kind of intervention at all. So head and neck cancer is in and of itself an intervention, as is a heart attack. Many patients will quit after they are diagnosed with a life-threatening illness. We are seeing in the second year a kind of a U-shaped thing. Those people who make it to 1 year are feeling a little bit confident, and those rates are picking back up again. The same thing with alcohol, and you want to look at the calorie intake. We use the Willett questionnaire, and you see that the calories 1 year later are about 300 less a day. And the BMI of the population, you can see also the drop in the BMI over the course of a year. Now, I want to point out that our patients come to us at baseline, this is pre-treatment, with a BMI of 26.4. The average for the population is about 30. So even pre-treatment, I think we have the only population in the United States that is not suffering from the obesity epidemic. Our patients just are not heavy. It's not a problem for them. We also look at their physical activity. Their physical activity scores, even at baseline, are higher than population means. We find that many of our patients are construction workers. They have jobs that are keeping them moving. So they're not generally high-level office executives. There are some, but for the most part, they are population, half of them with a high school education or less, who are in jobs that are keeping them somewhat physically active. We also know that they like to hunt in the fall. So there's these other kinds of activities that they're active in. And we kind of, by the seat of our pants, added a sleep questionnaire. We found that their sleep scores are pretty low, and we are looking at some sleep problems that were in this population. We're trying to explore those a little bit further as well. So this shows you a little bit about the interrelationship between the health behaviors. We see a high correlation between smoking and drinking, almost impossible for our patients to quit smoking if they are still drinking. We see that, of course, age does decrease these rates. These are logistic regressions. And being married does help smoking cessation as well, marriage being a marker of social support. Drinking is also less among the women in the population. These are kind of hard to see, and I have extra handouts up here if anybody wants to pick one up. But again, looking at some of the things that are happening, we have under calorie intake at 1 year, we see that being married makes a difference in the number of calories that you're taking in. I had a student working with me on a paper, and he said to me, well, obviously, the people who aren't married, the men who aren't married, their wives aren't cooking for them. They're not eating as much. And I said, well, that may be true, but probably not politically correct to write in this paper. So anyways, again, we see that going across high school education has an effect on the BMI, with those of lower SES having higher BMIs, and that is something that is also mirrored in the general population. We see physical activity and sleep highly correlated. And we also see some things affecting sleep, which are interesting. One of them is nicotine. It's very little written on this, but nicotine is a stimulant. If you smoke, it's liable to keep you awake. It also causes people to wake up with nicotine cravings. So the health behaviors are interrelated. The smoking and sleep thing we're seeing more and more of. The other thing that's well documented in the cancer literature is the relationship between depression and sleep. We have over 40% of our patients are depressed, and that is affecting their sleep. Just to give you a survival analysis here, we see that smoking remains the #1 predictor of poor survival in our population. We do not, by the way, see any effect of problem drinking in terms of recurrence, survival, or quality of life. It may be a quality of life issues for the families, but apparently it is not affecting at least our outcome measures as of yet. We also do not see any relationship between physical activity and survival. That's very different than some of the more hormone-related cancers like breast cancer or prostate cancer, where physical activity is predicting survival. We are not seeing that in this population. We looked at fruit and vegetable intake. We see that fruit intake is a big predictor of survival. And I'm going to show you a survival curve on that, where vegetable intake did not show any effect on survival. So there might be something with fruit intake that is predicting survival. And there are some of our control variables that are predictive as well. Things you might expect, like cancer stage and comorbidities. So that is our smoking curve, and former smoking helps a little bit, but definitely never smoking is better. Not a whole lot new there. This shows you a little bit about sleep. Oh, did I not? I probably didn't mention that. I can't go backwards anyways. I'm looking at whether or not sleep was in this model here.
Yes.
Yes, it is, in predicting survival as well. So that's why I spent a little bit of time on sleep, because the people who aren't sleeping also aren't surviving well. So that's kind of another missed opportunity. I'll mention a little bit more about sleep. I mentioned about the nicotine and the depression, but there are some other issues that are really unique to head and neck cancer patients. One is that a lot of them have xerostomia or dry mouth from their radiation, so they drink a lot of water during the night. They have to keep their mouth moist. That also causes them to have to get up to go to the bathroom a lot during the night. So that is another problem that could be interfering with sleep. They also have obstructive apnea. But the apnea is very different from what we see in the general population where people are really obese. They're not obese. The apnea is caused more by airway issues related to the disease. And sleep is just an untapped area. We don't really know. I mean, I have a sleep score and that's it. We really want to explore more what about the sleep that's really keeping these people awake, especially because it is a predictor of survival. Let's see. So we see the differences in sleep. There's a nice survival curve for sleep. Fruit intake. I want to talk a little bit about this. So the bottom line is the one that's really falling out. And this is 1 to 3 fruits a month. So everybody says, well, of course 1 to 3 fruits a month. That's ridiculously low. Well, what's astounding is 1/3 of our patients fall into that category. These are tertiles, or however it's said. So 1/3 of our patients at baseline, pre-treatment, respond to the question, over the past year, on average, how many fruits do you eat? 1/3 of them eat 1 to 3 per month. It's astoundingly low. So we talk a lot about nutrition interventions in terms of protein and calories, but I'm not sure how much we've really paid attention to the fruit intake and possibly vegetable as well. I'm going to just brief over this. I'm starting to look a little bit at some of the psychosocial type variables. The things that are really popping up, are people familiar with the POMS? And as well as, we looked at the POMS. We also had a couple of questions toward the bottom. Hopelessness, which is a 2-item question developed by George Kaplan. It's different from helplessness. You can feel helpless but still feel hopeful, but this is hopelessness, kind of like I give up type of thing, is showing up for us on recurrence and survival. Optimism, there's been lots of talk about optimism and the life orientation test. It's been shown in one other study with head and neck cancer patients to predict survival. And then spirituality is another one that we're showing to be predictive of recurrence and survival. This is also shown in the general population, which is kind of interesting. Unfortunately, there are a few studies that can control for a lot of other things like health behaviors, and so we're hoping to get our sample size big enough so that we can have more control variables in the model. We haven't been able to do that yet. We only did this with about 100 and some patients. And, oops, this is, all right. So getting a little bit to the markers, this is a survival analysis looking at interleukin-6, which is a measure of the immune system. It was a measure that was not originally identified by the basic scientists, and I'm very proud to say I found this marker in the smoking literature. I was seeing interleukin-6 associated with smoking. I didn't know a whole lot about it, and I thought, well, a lot of our patients smoke. Let's take a look at it and see if it predicts survival. And so we did do some analyses of interleukin-6, and lo and behold, interleukin-6 did predict survival. And so that gives you a little bit of idea about one of our markers that is showing up for us. So you see the team is starting to meld now. I'm looking at markers. They're interested in smoking. Boundaries are beginning to cross. This shows you the survival curve for interleukin-6. And so then the question is, well, what causes interleukin-6 to be high? Who are the people that have high interleukin-6? And lo and behold, here they are. They smoke, they don't sleep well, and they're depressed. So you get right back to where you started. So the question that we started out with, is it the markers? Is it the health behaviors? It's all of those things. Those things are really working together. Those health behaviors are really depressing the immune system. Let's see. We do also look at human papillomavirus. We've looked at it in a small sample of head and neck cancer patients, I think about 200. And it's a pretty typical story with the human papillomavirus, more common in the pharynx, coming in at a higher stage, although survival rates are longer for human papillomavirus, and it's inversely related with smoking. So people who don't smoke are the ones who pick up on the human papillomavirus. So again, the interrelationship between those health behaviors and those molecular markers. So I paint for you a little picture of what I think is going on with the head and neck cancer patients. If you could just ignore the circle for a minute and focus on the squares, the stress is in the form of getting a cancer diagnosis, and that for at least half of our patients is pretty depressing. And that depression makes it very difficult to engage in healthy lifestyle behaviors. It makes it very difficult to quit smoking. It makes it difficult to sleep. I don't have it up there, but it may also affect their dietary habits. And also the health behaviors that I don't have up there, there is some much discussion about HPV positive cancer tumor being related to sexual activity, so that again is yet another health behavior. Those health behaviors and mood disturbances can lead to immune downregulation, as we saw with IL-6 as being one marker. And we have other clinical and treatment characteristics and demographics feeding into that, and all of those things working together to affect quality of life, recurrence, and survival. Back to the circle, it is that area of the circle where we see really missed opportunities for intervention. Much of what's been going on has been in the area of treatments and markers and so forth, and that is what a lot of the people in this presentation are talking about, doing those interventions for smoking, perhaps alcohol, although we're not showing up, for depression, body image, and again, some missed opportunities perhaps in the diet and sleep area. So with that, I give you paint kind of a picture of the head and neck cancer patient and kind of pulling the whole story together.
Bennett dinner!
Anyways, kind of cute, but kind of depressed guy, smoking, isolated, depressed. Anyway, thank you very much.
Okay. Sonia. That was a great talk. I feel for that dog. We are going to skip questions at the moment to give Dr. Day his full time, and please feel free to stay afterwards to ask questions of all of our speakers. Dr. Terry Day received his medical degree from the University of Oklahoma, then went to LSU for his residency, and then pursued a fellowship at the University of California, Davis, and in craniofacial maxillofacial surgery at Inselspital Bern in Switzerland. He was at Vanderbilt University and is now Associate Professor and Director of the Division of Head and Neck Oncologic Surgery in the Department of Otolaryngology, Head and Neck Surgery at MUSC in Charleston, where he's also the Director of the Head and Neck Tumor Program at the Hollings Cancer Center. He's past chair of the Coordinating Council of the statewide South Carolina Cancer Alliance and has multiple leadership positions in the AHNS and the American Head and Neck Society and at the NCI. His practice is limited to the treatment of patients with tumors of the head and neck. He also volunteers his time as president of the Yul Brynner Head and Neck Cancer Foundation. I thought he died of lung cancer. And in 1998 started the first Head and Neck Cancer Awareness Week, which is now an international event occurring annually. Terry.
Thank you, Ellen. Yes, he did die of lung cancer. But he started the foundation when he had a pre-malignant laryngeal lesion before doing the King and I in Chicago. So he smoked 5 packs of cigarettes a day and then apparently quit cold turkey because nobody ever told him that the smoking can cause cancer. So people were scared to because of his personality to tell him to do anything. And so then he quit and started the foundation, but then a year later was diagnosed with lung cancer. So I really enjoyed those presentations. That was fabulous work by everybody, and this is a bit of a switch in gears. I'm a surgeon, but I volunteer my time trying to educate the public and health professionals on head and neck cancer. And so I'm going to give you a brief update on what's going on around the world and how we can all work together. I think the multidisciplinary team in each area is the key to this, and once you get those parties together, things just start snowballing after that. We do have some research with Dr. Han Yoon. He does driving ability in head and neck cancer survivors that are 5 years out from treatment, and we do have some tobacco and alcohol research as well. Thanks to the panelists for some great presentations. And my disclosures, all of these are voluntary, except the final one. I give some lectures that I get an honorary for with companies at the bottom. This was a study we presented at the CDC conference. So this is a background on why we need to educate the public and health professionals. And if you, let me show you the first one. We did a telephone random digit dialing survey of the U.S. public, 18 and over, to find out what they knew about head and neck cancer. And the first thing we realized is they don't even know what the terms oral and head and neck cancer mean. And for example, 25% thought brain cancer was included in those categories. And at the bottom, 49% didn't know what oral or head and neck cancer was. In addition, approximately 3/4 thought they had never been examined for oral cancer. And obviously, a very small percentage of those that, in the total, and those that use tobacco products, 10% knew the early signs and symptoms of oral cancer, and only 1% knew that a change in voice was an early sign of laryngeal cancer. So if we're going to educate the public, we've got to understand what we're educating them on, and this, in effect, for head and neck cancer purposes, is prevention. And there are three main types of prevention. Primary is preventing the onset of the disease. Secondary is once there may be a cancer-causing situation occurring, is preventing that progression. And in tertiary, once you're diagnosed with head and neck cancer, reducing the morbidity and potentially mortality. We've done some studies with Dr. Sue Reed in our dental public health area on educating dentists, dental students, and medical students. And we found that the dental students were very unaware of the lymph nodes related to oral and head and neck cancers and tobacco cessation, whereas the medical students were very uneducated, if you will, on the oral cancer exam, the mouth exam, understanding the early signs and symptoms of oral cancer per se. And so today I'll spend a little bit of time on each of these, reviewing ongoing international awareness programs related to head and neck cancer, discuss the role of screening for oral cancer, and understand how we can start an awareness program in each of our communities. It's a difficult problem when you talk about prevention of head and neck cancer, and that's because head and neck cancer doesn't really mean anything in the way of prevention of head and neck cancer. It's such a generic term. There's so many cancers that fall into these categories that you've got multiple etiologies, multiple sites, risk factors, and if you're talking worldwide, every country has a different situation or problem related to even educating them on the disease. So what I did was a Google search on recently on these terms: head and neck cancer awareness, oral cancer awareness, laryngeal cancer awareness, and then I excluded the other sites in the head and neck for time purposes. And then I went through each of these websites, the top 30 websites, to find out which of these programs were organized. And this was done just a few weeks ago. And for head and neck cancer, and those terms were used, this is what we found. And these are the organizations. Most of these are not-for-profits, the majority in the United States, some international or based in Europe, Great Britain for the Mouth Cancer Awareness Week, an international consortium, and the UK for the Mouth Cancer Awareness Foundation. For oral cancer, a very similar group, maybe a couple of differences here with ADA, and down near the bottom is oralcancerawareness.org. This is in India. And so in general, I'll show you what these organizations do in just a minute, but I'll show you the difference between the sites. And when you look at larynx cancer, it's quite a bit different. Very few organizations are involved in larynx cancer, which is, in many cases, a different etiopathogenesis, diagnostic, and potentially treatment. So this differed significantly from oral and the terms head and neck. So these are the organizations that provided either support, advocacy, detection, prevention, education, or research around the world related to awareness of head and neck cancers. And you can see just a number of different organizations, not-for-profits, and some of the national, the Academy of Otolaryngology, the American Dental Association. And then as far as research and clinical trials and potentially advocacy, you see a little bit different subset here with the cooperative groups. You see NCI, EORTC, the Head and Neck Society, and so on. And so there's quite a bit of difference in what these organizations do and their missions as well. And so trying to get these people together has been difficult over time. Finally, however, related to oral cancer was the Crete Declaration, and this occurred in 2005 at the World Congress on Oral Cancer, and one of the things that was recommended there is dissemination of information on oral cancer, prevention and care through every possible means of communication. This was then followed up by the International Consortium on Head and Neck Cancer Awareness, and that's where a number of organizations over on the right came together. This is published in Oral Oncology, and decided that in 2010 there would be a worldwide Head and Neck Cancer Awareness Day that hopefully will combine every organization around the world for one day agreeing to support this, this proposal. The awareness activities that are directly involved with these organizations include awareness weeks, free cancer screenings, survivor support mechanisms and chapters, advocacy, tobacco cessation, curricula changes and improvements related to oral and head and neck cancers, and running events and walkathons. Finally, also, the National Cancer Institute has an area on their website for oral cancer prevention. This has been many years coming, but it does address prevention, including tobacco, alcohol, sun exposure, and HPV, as well as chemo prevention. And so this is a great step forward. The American Cancer Society had one in the year 2000, but it's since taken that away. This was mentioned earlier in the keynote address, and this is very important. Finally, the World Health Organization, through this framework convention, is addressing tobacco and human rights around the world. And there will be that meeting in August as well in Switzerland. And this is really a big step forward. And so we hope that when people are going out in their communities and their states and addressing tobacco control, look over this framework, because it really gives you a good idea. There's no need to duplicate efforts that are already ongoing, and they've outlined various issues that you will be contending with. As far as screening is a very difficult problem, and each site in the head and neck may be screened differently. It may be a visual exam. There may be technologies available to identify cancers, maybe some serum tests or radiography, and each site should be different. So when you say screening, it's very important that the screening is linked to the exact subsite or type of cancer rather than using the generic term head and neck cancer. The United States Preventive Task Force has identified that there is insufficient evidence to advocate for or against screening for oral and head and neck cancers, and they have done a very good job of looking over the evidence. There's significant issues related to screening, population versus the high risk, false positives and negatives, and is there any effect on mortality or morbidity, and that evidence in the United States is still lacking, and the potential liability for screening or not screening and how you're going to follow patients that have been screened. However, in 2005 in Lancet, finally the first article and study that showed a significant change in cure rate in oral cancer based on screening. They screened over 190,000, or they had 190,000 people in the study in India, and about half were screened, half were not screened as the control group. And there was a significant difference in the death rate. And the principal investigator estimates that 37,000 oral cancer deaths may be prevented with high-risk screening. So how do we start this event in our community? I think everybody that's in here is probably already involved in awareness programs, particularly with tobacco, but getting that multidisciplinary team together is the first step. Once you find these individuals, it starts happening. And so what we recommend is engaging, and when we started this Head and Neck Cancer Awareness Week in '98, there were 3 places in the United States that participated. Now there's over 130, and I think we had about a dozen countries involved. But the first thing is to find interested healthcare providers and researchers. Join an awareness program if it already exists. Otherwise, start your own. You can offer screenings or other publicity in the United States. The New York NYU Oral Cancer Consortium is probably the largest and does the best job of organizing this. There's also other organizations that are involved. Educational events to middle schools has been very successful, and survivor support banquets or survivor support events is also very helpful. And in addition, that gets the survivors on board so they can understand the need for participation in clinical trials. And that's really been successful. A research conference as well. So the key personnel: physicians, dentists, dental hygienists, nurses, speech pathologists, cancer survivors, nutritionists, researchers, and epidemiologists, in addition to marketing and PR contacts. And this is an example of a sample head and neck cancer awareness week that can happen, and it may include any or all of these, but it's customized to a person's particular location. So really the goal is that all of these organizations will combine, and we can then consolidate all of these awareness programs and help move forward not only with tobacco but cancer prevention, and if we can get the organizations to talk to each other. And this is the dates for the 2009 event, and there was a map of all the screening sites in the United States. And so in summary, head and neck cancers represent a variety of tumors that do not have a common target for prevention and awareness. Combined efforts of governments, not-for-profits, academic medical centers, and industry are all necessary to impact this disease worldwide. Thank you very much.
We have a few minutes left, and I welcome questions now for all of the speakers. If you have a question, could you please come to the microphone?
I have one.
Good.
For all the tobacco researchers here. In our head and neck surgery practice, the majority of our patients come from 2+ hours away at a minimum. And when we ask them to see our psychologist or our tobacco cessation counselor, they all agree in the room and then fail to make that walk across the hall into the room to get that counseling. And when we schedule their follow-up, they don't keep that. They'd like to go back home for their treatment and their follow-up, and that's been our constant difficulty in getting them engaged. So I know all the research, it's great and easy in our controlled clinical trials groups, but how do we expand that to the general population and other community health centers?
Well, I'll take an initial crack at it, and then Robbie and Sonia and Michelle may respond. What we have at MD Anderson, a comprehensive tobacco treatment program that's free for all patients, and it's an actual clinical program, gives them free medication or free counseling. So you have to get them to the initial counseling. And maybe if you have a Michelle sitting next door to you, you can actually bring her into the room to lead the patient out. But that is critical. And then everything else can be done by telephone. But if you can't get them to the initial consultation, it's really hard. Michelle or Robbie or Sonia, do you have anything to add?
Just that as public health problem across all populations, when we screen patients for other clinical trials, participants for other clinical trials, about 70% of them who are eligible don't receive treatment. So it's not just a patient issue, it's an issue. And there have been people that are talking about motivational interviewing as a very popular potential technique that shown to be effective for alcohol addiction. And unfortunately, most studies have been less than positive. But I think unfortunately our field is still how to increase the utilization of effective treatments.
So Dr. Schnoll has said this is a public health problem that reaches across diseases and the general public as well, and that motivational interviewing has been tried as a technique for those who are not yet stated ready to quit. It's shown some positive effects for alcohol, but hasn't yet been positively indicated for all health behaviors. Sonia, can you go to the mic maybe? Yeah. Why don't you go to the mic?
The only thing that I would add is I think it's a big health services issue as well. It's how you deliver, because we find that if it's an extra thing our head and neck cancer patients have to do, they're not going to do it. They have radiation appointments. They have so many things going on. They're sick. They're exhausted. And so you have to do it right during the visit. And there's also a Cochrane Collaborative review that says that nurses are well positioned to do it because they have direct access to the patient. And if the nurse can get them right at their clinic appointment and do the intervention right there, it's almost like they're a captive audience. They don't have a chance to refuse. I mean, that's from a clinical standpoint. Of course, any kind of research study they're going to have to consent to. But it's just part of the treatment plan. It's just like the same way that you would offer radiation or chemo or anything else. It's right there as part of the clinic appointment. And I think that health services piece is very important as well.
Yeah.
The other thing I'll add to that is it's also a matter of how you frame things. So one of the models that I put up in my talk was for a behavioral health consultation service, specifically using those terms, behavioral health consultation, as opposed to psychology, mental health, or something of that nature, because that obviously can scare patients away. So the idea behind this model is you have somebody come in who's a behavioral health specialist, and later on they will discuss their training and things of that nature, but it's to not frame it as it's related to mental health or psychiatry or something of that nature. That can help eliminate one of those barriers to getting in the door.
Yeah, and the surgeon or whoever, what other physician is seeing the patient also has to emphasize that this is as important as whatever medical or surgical treatments will follow, and that will affect their survival. Any other questions? Yes, okay.
I'm Heather Wallace from the University of Kentucky in Lexington, and this is more of a comment, but I'd welcome anyone's feedback as far as most of our patients that we see come from Eastern Kentucky, Appalachian region. And in the past, we've really focused on the smoking versus kind of framing it as tobacco. So what we've found is we've been really concerned with getting people to stop smoking. In some of these counties that they come from, 30% of the population smokes. And what we've found later is we've kind of claimed this success that we've gotten people to quit smoking when they've actually been using smokeless tobacco products or adding smokeless tobacco products to their repertoire, and in addition to that, also using narcotics and methamphetamines in that particular population. So just something kind of for the radar screen as far as doing this type of research. How do we kind of assess all of that and get people to stop as far as health behavior? And just wondering if any of the speakers have really had a similar experience and like the multi-use of different drugs, I guess.
Yeah, well, smokeless tobacco was mentioned by Dr. Dressler as now an increasingly heavily marketed product to healthy individuals. And of course, the U.S. South and West have been the traditional areas for smokeless tobacco use, even in the old-fashioned kinds of chew and spit. But I think you're right that it has to be framed in the most broad way of all substance use. And when you're talking about, you need to talk about all forms of tobacco. Okay, we are officially out of time, but again, I welcome anyone to come and say, talk to the speakers up here. Thank you very much for coming. Great, Terry, terrific. Can you send me your slides just so I have them for my...
Nice man, you want to go visit him, but it's kind of like they're, because he's pretty bright.
Oh yes.
And even she's, what happened here is the tumor didn't hurt her.
It's too, well, it's
every
too
once in a
bad.
while I see people where the tumor didn't hurt them, so they did dumb things, and they somehow think they're going to way over.
Now, which one is he advanced? Is it?
I don't know.
This is okay. I think this is next back pointer. This is fancy. Wow.
Sitting here with this
Different control. I don't know. Oh, there it is. Pointer. Hey, how are you? I enjoyed your talk on that last panel.
I got through about 2/3 since we're
Yeah,
running, but
I know. Yeah. Anyway, it's good to see you again, Todd. So, Steve, buddy, what's up?
How exciting.
Yeah.
Huh? I don't know.
Somebody came up and said that my picture showed up in your talk. That's great.
So I'm just looking for your
Sure. Okay. Great. Whatever.
You've probably done this 200,000 times. This is like,
Oh.
how am I giving you like 200,000?
No, just whatever. I have 2 daughters, 5 dogs, was my department chairman for 13 years, and she's still my boss, and so I just go with the flow. So
You seem like a very mellow man. I like that.
I don't get real excited. I get along pretty well as I work with Steve. For
exactly right.
And you left this guy?
I didn't. I was a resident under.
I threw you out. That's what it is. I'll tell that story. That's the
He was
story.
more than
I'll
happy to
probably
get
take
rid of
from
me.
here.
Probably almost a year short.
I'll keep hold of this, and then I can do it. Good afternoon, everybody. I think we've right on time starting our session this afternoon on locally advanced laryngeal cancer. We have four fabulous panelists here to discuss their side of the story, radiation oncologists, surgeons and oncologists. And I'm just going to lead off with a very brief introduction to what it is that we're talking about here. I'm a radiologist at UCSF, and my specialty is in head and neck cancer specifically. I would like to disclose that I'm a consultant for and an investor in AHNS, and the only thing that will pertain to my talk is these sort of diagrams that I use are from AHNS, and that is all. So this is our panel for this afternoon. We're going to look at locally advanced laryngeal cancer, the role of radiation therapy, IMRT, and then chemotherapy. And then we're going to finish off, I think it's a little bright in the room to see this. We're going to finish with a very interesting aspect of management of glottic tumors by Steve Zeitels. So what is it that we're talking about? Well, the American Cancer Society estimates that in the US this year there will be over 12,000 new cases of laryngeal cancer and over 3,500 deaths from laryngeal cancer. So we're talking about a reasonably sizable problem here. Over the last 2 decades, there have been many changes in treatment options, with the end result being that we're looking to try and preserve the larynx whenever possible. So these are changes in surgery for partial laryngectomies, as well as radiation and chemotherapy regimen changes that have happened in the last 2 decades. We're talking about squamous cell carcinoma clearly, and again, nothing much has changed as far as the etiological factors. Smoking particularly as the most common number one predisposing cause. It's much more common in urban areas, and male predominance is seen. There is, however, a little change in the demographics, with an increasing proportion of minority race patients developing laryngeal cancer. And this is particularly seen when you look at the data in black women, and it's presumed to be related to the concomitant rise in smoking in these groups. Of course, John Wayne didn't die from his laryngeal cancer, he died from his gastric cancer. So what are we talking about? Well, the presentation stage we're looking in gastric cancer, we can divide into the early and late groups. So about 60% present in this early group, with the T in situ cancers obviously being stage 0, but the T1, T2, the small tumours without nodal metastatic disease, being the stage 1 to 2. And of course, there's a very good cure rate. 75 to 95% of these T1 and T2 no nodal metastases will be cured. We're really focusing more on the late cancers. About 40% of the laryngeal tumours are in the late group, so that's T3 or later, at least one lymph node, or metastatic disease. More than half of these tumours are glottic tumours arising from the true vocal cord, with about a third being supraglottic and a very small 2% being actually subglottic tumours. This, not otherwise specified when you look at the data, is really usually very advanced tumours involving multiple sites where it was very difficult to tell where it arose from. And then there's a very small percentage from other locations. So glottic squamous cell carcinoma, most of these patients, as you know, presenting with hoarseness. Most of the tumours are in the anterior half of the true vocal cord. Here are a coronal schematic, and on the coronal CT image, reformatted image. And because this is very dense fibroelastic tissue without lymphatics, it's very uncommon to have nodes at presentation, and unless you have late spread, so you already have supraglottic or subglottic spread, which is going to result in nodal metastatic disease. We're really concentrating on this T3 or T4 staging group here, those that have either cord fixation or paraglottic or cartilage erosion, paraglottic involvement, cartilage erosion is the T3, or the T4 group, where there has already been erosion through the cartilage into the extralaryngeal tissues,
or posterior erosion into the, around the carotid sheath into the prevertebral space or mediastinum. So on the image on your left is a stage 1 tumor. This is one of these small lesions confined to one vocal cord. You can just see a dense, thick appearing right true vocal cord here. This is a stage 1. The patient to the right, you can see involvement of the right cord, very thick, dense, enhancing cord, involvement across the anterior commissure to the left side. But this patient had altered mobility, which made the patient T2. In comparison, a T3 and 0, a stage 3 tumor, clear involvement of the paraglottic space in this patient, and below that, a very obvious T4A, quite clear anterior extension through thyroid cartilage into the prelaryngeal soft tissues. These are not very difficult for your radiologist. The difficult problem that we find is when it's very subtle cartilage involvement. It's enough fodder for another lecture. Comparison to supraglottic tumors, there are a number of different subsites clearly from which a supraglottic squamous cell carcinoma can be arising. These patients do frequently present with lymph nodes, and they're often bilateral lymph nodes. They'll present with either enlarged nodes in the neck, looking for the primary, or sore throat, difficulty swallowing, referred ear pain, typical clinical presentations. Again, the late stage we're looking is the T3 and T4 we're focusing on for the first part of the session this afternoon. Cord fixation, obviously something that the clinician does way better than a radiologist does, or invasion of the preepiglottic, paraglottic spaces, or the postcricoid region of the hypopharynx. The T4A and B is the same as it is for the glottic group. So these are two cases. A case on the top, the patient has preepiglottic space involvement, clear involvement of the preepiglottic fat, which should be uniformly hypodense on CT, while the patient on the bottom has paraglottic space involvement of this supraglottic primary tumor, clear T3 on both cases. The lower case has no contrast as the patient had renal failure, but not only was it into paraglottic fat, this extended all the way down to the level of the true cord. The last group are the subglottic group. These are extremely uncommon, about 2% of all the laryngeal tumors. They do tend to present very late. About half of the patients will present with T4 stage at diagnosis, so that is clear extralaryngeal spread at the time of diagnosis. Again, extralaryngeal spread, T4A, if it goes posteriorly, is T4B, and T3 again is the cord fixation. It's very hard to find good cases to show you of a T4. These are often really messy when they present, but this is clearly a subglottic tumor extending out through the cartilage into the thyroid gland at presentation. Just to quickly mention the end staging, which is going to alter the overall staging of the patient. The presence of one lymph node, as you know, is going to take the patient to N1, and this is going to be a stage 3, 2 nodes, contralateral, stage 4A, and a nodal mass greater than 6 centimeters. We're already at stage 4B. So what are our treatment options? Well, with advanced laryngeal carcinoma more than 2 decades ago, this was pretty much it. Total laryngectomy and radiation therapy was what we used to do 2 decades ago. And since then, there have been enormous changes. And we now have a whole array of different things that we can do for this group of patients. There have been a number of advances in surgical options, partial laryngectomy, either open, such as a supracricoid partial laryngectomy, or the laser, the carbon dioxide laser, the endoscopic resection, and with or without radiation therapy. Radiation therapy alone can be used as a definitive treatment, and Dr. Mendenhall will be talking about this later, right following this. And then we have a number of different chemotherapy and radiation therapy regimes. Of course, the VA Larynx Cancer Study Group study, which was published in 1991, was quite a landmark study which suggested that you didn't need to take out the larynx anymore. Now, induction chemotherapy and radiation therapy would have similar survival, and these patients did much better as far as they obviously had laryngeal preservation initially, and 2/3 of this group of patients would then preserve their larynx. But not only that, these patients were a lot happier than the patients who'd had a total laryngectomy up front. So that was obviously a significant improvement with the same survival statistics. The RTOG trial, which was then came out in 2003 with concurrent chemoradiation, changed things again a little bit further, showing again similar survival to the induction chemo and radiation therapy groups, but these patients had an even higher laryngeal preservation, and by that I mean that they didn't go on to total laryngectomy for failure of treatment. This group of patients, of course, if they did fail, also had a lower incidence of distant metastasis. So this was clearly an advance in our treatment of late-stage laryngeal tumours. Then, of course, we have the third option, which is induction chemo with concurrent chemoradiation, and then newer options coming in, the targeted therapy. So things have kind of changed a little bit from the surgical total laryngectomy approach. We've now brought in a number of other options, partial laryngectomy, either open or endoscopic. So things have kind of changed a little bit from the surgical total laryngectomy approach. We've now brought in a number of other options, partial laryngectomy, either open or endoscopic, radiation alone, chemoradiation, which can have 3 different flavors, with, of course, if these fail, going back to total laryngectomy. So there's definitely been a number of trends over the last 15 years with a decrease of initial total laryngectomy in patients and an increasing use of this chemoradiation or radiation alone, or a combination of one of the larynx-sparing surgical techniques to try to keep our good results for patients, but at the same time improving their functional outcome. So this all sounds really good, but there are some trends that are a little disturbing when you look at literature, and that is this trend of declining survival in the US for patients with larynx cancer. And it's one of the few malignancies for which survival is not improving. And this is the SEER data, which actually just comes to 1999, and you'll notice that the concurrent chemoradiation was not published until 2003, and the supracricoid partial laryngectomy was only published in 91. But it does show that larynx cancer overall has been declining in survival from a peak here in 1980-82 to a 5-year relative survival in 92-99 of 64.7. And this is in comparison with all other cancers. And by all other, they took 24 cancers total, and larynx was the only one for which survival was declining. The others were improving. The National Cancer Database also suggested a similar result with a declining survival. This is glottic, supraglottic, and then all sites of the larynx from 1985-87 to 94-96. So it's a little concerning that we're not actually getting better in the larynx. Now, does this relate to not using surgery? Well, it doesn't really exactly parallel the introduction of some of the surgical techniques or the chemotherapy regimes. So it's all a little unclear. So now that I've muddied the waters a little, with a very brief introduction to larynx cancer, I'd like to introduce Dr. Bill Mendenhall, who is from Florida, who is going to speak to us this afternoon, on the role of radiation therapy in locally advanced larynx cancer.
Thank you. Okay, great. Thank you very much. Bob, my buddy's back there. There we go, great. So I'm going to give you my take on management of laryngeal cancer. And we'll start first with the glottis. I think of the glottis in terms of favorable and unfavorable, and it's based on tumor volume to a large extent. And this is not an absolute cutoff because there can be a lot of inter-observer variability. But when we went back and looked at our data, if a tumor is bigger than 3.5 cc's, particularly if you have cartilage sclerosis, the likelihood of curing the patient with radiation alone or radiation and chemotherapy is going to be lower. And also, the larger the volume, even if you do cure the patient, you are more likely to have a larynx that's not going to function properly. We don't treat very many T4s with definitive radiation. The ones that we do are low-volume T4s based primarily on exolaryngeal extension of tumor through the cricothyroid membrane. So if we have a high-volume T4 with cartilage destruction, then I really don't think that that's a patient who's likely to do well with radiotherapy. Unfavorable tumors, high-volume cartilage destruction. If you have a patient who has to have a tracheostomy before treatment, then almost certainly that's going to be someone who's not going to do well with radiotherapy. One of the things that occurred with the last edition of the AJCC is that patients who had T2 cancers in the previous staging system with paraglottic space involvement were upstaged to T3, even if the cords were mobile. And this, to me, is an example of stage migration. We still stage patients as T3 for glottic cancers only if they have fixed cords. And so essentially what happens is you wind up with the Will Rogers effect, where your cure rates go up stage for stage, but the overall cure rate doesn't change. And we went back with Tony Mancuso and looked at a subset of patients where we were able to pull the pretreatment CT scans and look for paraglottic space involvement, and we looked at other parameters as well, like cord mobility and so forth. And what we found was that within the patients with T2 glottics, the involvement of the paraglottic space did not have any impact on local recurrence or survival. So I'd implore anyone who's involved in the next sort of round of the AJCC to make a change and put the T2s with paraglottic back in the T2 sort of stratification. So treatment guidelines: low volume favorable. T3, T4s we treat with definitive radiation. Nowadays, since like 1997, we use concomitant chemotherapy. Patients who are suitable for an open partial laryngectomy, or we don't have anyone at our place who's doing transoral laser on T3s, but if you have someone and they think they can do it and leave the patient with a good functional result, then that would be an option. High volume, unfavorable patients, I still think that there's a place for total laryngectomy, and then most of these patients would get post-op radiation. And I thought the data that you presented was very interesting on the decrease in survival, and my interpretation would be that we are treating some patients with really high volume lesions that would be better treated surgically with chemoradiation, trying to salvage them, and probably not doing as well. Now, this is some old data from our place, and this looks at a series of patients treated with either radiation alone or surgery, mostly total laryngectomy. And if you look at the outcomes for these two groups of patients, and early on, we really only treated patients with radiotherapy if they refused surgery. By the early 80s, we were trying to select out the low volume favorable patients. So these patients are, in general, going to be more favorably selected than the ones in this category. But nevertheless, if you look at local regional control, ultimate local regional control, survival, and severe complications, and this counts all major complications. So whether it's post-op, acute, late, post-neck dissection, but the incidence is almost identical. And there's some data that was published by Rob Foote from the Mayo Clinic looking at a series of patients treated surgically, and the numbers are almost superimposable. So at least in our hands, we have not seen a decrease in survival in the patients we've treated with definitive radiation. And this, again, is complications, and we code as severe, either acute or late, related to the initial treatment or salvage treatment that necessitates hospitalization, surgery, or results in death, and incidence is the same after definitive radiation or surgery, plus or minus RT. This is an update of our T3 patients. Most of these patients were treated with radiotherapy alone because we really only started using concomitant chemotherapy in 1997. Before that, we treated a few patients with induction chemo, but starting in 97, if a patient gets chemotherapy, it is concomitant with radiation. We do not use induction chemotherapy. And if you look at the 5-year local control rates for the T3s, 67%. T4s, again, this is a very heavily selected group of patients that have low volume lesions and certainly not reflective of what you could do if you treated all the T4s, but properly selected, very good local control rates. This is some data that was published by Frank Pallmeyer with Tony Mancuso about 10 years ago, and looks at a subset of the patients with the T3 glottics, looking at tumor volume and cartilage sclerosis. And if you have a low volume tumor and very little, if any, cartilage sclerosis, you have very high local control rate. And then as the volume goes up, and if you'll recall, if you have cartilage sclerosis, you have about a 50% chance of having invasion. If you look pathologically, your control rate really drops. So you can use this kind of information to select out the patients you're likely to cure with radiation. Switching to the supraglottis, treatment options, transoral laser, open partial laryngectomy, definitive radiation, and then total laryngectomy and neck dissection for the high volume unfavorable patients. Our guidelines are if you have someone who has a tumor that's anatomically and medically suitable for partial laryngectomy, then that's how they're treated. And we try to pick patients who are not going to need post-op radiation because I really don't, in general, patients, at least in my experience, don't tend to tolerate post-op radiation very well if you have to treat the larynx after a partial laryngectomy. You have to drop your dose and drop your dose per fraction. Low volume favorable, we treat with radiation with or without concomitant chemo, depending on the volume of the primary and the next stage. And again, these would be patients not suitable for partial laryngectomy. High volume, unfavorable, would be treated with a total laryngectomy. And we went through a phase both with the glottics and the supraglottics where we treated patients with high volume tumors with definitive radiation, and we also tried induction chemotherapy and then tried to base the decision whether to triage patients to definitive RT on the response to induction chemo, and basically didn't work. They did not do well. And so these are the local control rates. Looking at the T3, T4s, you cure about 2/3 of them with radiotherapy. And this was updated not too long ago by Russ Heinerman. This is some data published by Tony Mancuso a few years ago, looking at patients based on the tumor volume, and for the supraglottis and also for the piriform sinus, it seems to be higher than it is for the glottic larynx, and you tend to see the sort of the cutoff, and it's not an absolute threshold, but as you get above 6 cc's, you see the likelihood of local control after radiation dropping. Again, this is mostly radiation alone, not including concomitant chemo. Local control for the low volumes, almost 90%, drops to around 50%. And then the other point is that if you look at whether or not they're controlled with a functional larynx, there's a subset of the patients with the high volume tumors that may be controlled, but their larynx isn't going to work. They'll wind up with a trach and maybe a permanent G-tube, and you and they will probably both wish that you had treated them with surgery. In terms of complications, about a 4% risk of severe late complications. This is sort of my take on the literature as it pertains to altered fractionation and adjuvant chemotherapy. I think there are trials, particularly the RTOG, I think it was 9003, that show that altered fractionation, either hyperfractionation, which we've been doing at Florida since 1978, or the concomitant boost that was started at Anderson, are pretty much equivalent. They're both associated with improved local control compared with conventional once-a-day radiation. Concomitant chemotherapies improved local regional control and survival. Best I can tell, the optimal chemotherapy regimen is unclear, and the optimal number of cycles is unclear. And so what we do is we use altered fractionation. If we're treating with non-IMRT, we use hyperfractionation. If we use IMRT for logistical purposes, we use concomitant boost. And then we generally will give weekly cisplatin, 30 milligrams per meter square per week. I think another reasonable option would be the 100 milligrams per meter square every 3 weeks. Thank you very much.
Thank you very much, Dr. Mendenhall. The next speaker to talk more about IMRT specifically for the larynx is Dr. Steve Feigenberg, who's at Fox Chase Cancer Center in Philadelphia.
Thank you. That's not the beginning, huh? Okay. Thank you. I just want to thank the committee for allowing me to do this talk and actually follow my mentor, Dr. Mendenhall, since I trained at University of Florida at least a few years ago. So basically what I was going to do is go a little bit more into the technique of radiation and how it's actually changed over the last 10 years or so. And basically, I have no disclosures. And the outline of what I was going to try and describe is just go through some of the basics of IMRT, since I know that the majority of this audience may not be radiation oncologists, and I thought doing an introduction of exactly what IMRT really is important. In addition, I just want to go through the benefits as well as the limitations of IMRT and some of the clinical results, since the majority of results with IMRT is not in the group of patients with locally advanced larynx cancer. It's actually more with oral pharynx cancers, as well as talk about what I think could be the future of using IMRT. So basically, over the last 25 years or so, there's really been an evolution in how radiation therapy has been done using a two-dimensional radiation therapy. Huh? What, down here? Yeah, well, that was working. Yeah, I think that looks, yeah. And basically how things have changed is going from two-dimensional treatment planning using plain X-rays to basically using a three-dimensional treatment set or data set in which we use very similar fields and get distributions that are relatively similar to what we did in the past. And now in the modern era, or maybe I shouldn't say in the more, I guess in the modern era, of when we were standing upright over the last 10 years, we've been able to try and do things to actually spare certain critical structures with IMRT. And with this diagram, you can see that some of these lines, and these lines actually represent doses, and the closer you get to the skin surface, the lower the dose is. And what we can do by decreasing the dose to certain structures, we can decrease some of the potential side effects that people experience from radiotherapy. So when we look at conformal radiation, basically what the principles are is that radiation oncologists will identify the targets and will design the fields ourselves based on the typical patterns of spread from the gross disease to the regional lymph nodes that are involved, and then turn it over to the physicists and dosimetrists to get the optimal plan. Now, with the IMRT era, or three-dimensional conformal radiation era, we've actually, instead of using two fields coming in from the lateral directions, we use multiple fields coming in from multiple directions. We still identify the target volumes, but now we do a lot more contouring and it takes a lot more work. And now we have to identify all non-tumor structures because each structure that we don't contour, the computer doesn't see, and potentially can have more dose go to these areas, potentially increasing complications. And basically how we describe specify the dose is different. We tell the computer to prescribe a dose to the target, and then we also tell it to limit dose to certain critical structures, and that's how we develop a plan. And basically, just for an example, this is if this was a conventional lateral field on the left, I'll just say that this is what we do is we actually deliver the same amount of radiation through this entire field. With IMRT, this same exact field, actually, instead of having the same exact radiation, each one of these pixels by basically the color scheme will give a little bit different intensity of the radiation. And basically, when we add all those areas up, we get a distribution that can shape it the way we want it to. And basically what we try and do is, this is kind of what the computer is trying to do. This is actually for a larynx cancer that had a bulky involvement into the base of tongue, that this was the gross disease plus a margin to make sure we were hitting it. This structure here is the nodal involvement. This structure here is actually the spinal cord, and you can see that it's lighter in this area to try and drop the dose. And this is the area of the parotid, which you can see that it's not having any dose in that area for this specific beam's eye view. And basically what we can do when we put all those targets together, we can actually drop the dose to certain structures. And here you can see that you can drop the dose to the parotid glands to try and decrease some of the late morbidity from xerostomia the patients experience. So just to kind of take some old Florida data to go on Dr. Mendenhall's talk from before, one of the things that I was taught when I was at Florida is that the most radio-resistant cell is actually the cell that isn't hit by radiation. So this actually slide kind of demonstrates that, and they actually did where with posterior pharyngeal wall primary tumors that if you were able to cover the tumor, you had a better outcome. And this is basically one of the primary reasons why our IMRT can work and actually can have potentially better outcomes for tumors that are very difficult to cover. Although this is not always the case in larynx cancer as it is for posterior pharyngeal wall cancers. In addition, other structures that are very important to try and decrease the dose to try and decrease dry mouth, which is one of the most troublesome quality of life problems with radiation, is trying to decrease dose to the parotid. And that's primarily the reason why the IMRT is given. So maybe the reason why I was asked to do this talk is that I wrote a little editorial saying IMRT is not a good thing for patients with larynx cancers, although this is much different in looking at locally advanced as opposed to early larynx cancers. When we look at early larynx cancers, we don't see the potential benefit. Right now, you can use old techniques, or maybe I shouldn't say old techniques, I'll get in trouble for that. But techniques that have been used for a long time that have been very successful with very low complication rates. And you don't treat the regional lymph nodes, so you're not treating the parotid glands. So it's hard to say why we should use IMRT in that setting unless you think that it can increase risks of coronary vascular disease or carotid vascular disease by causing increased strokes. And actually, this is a project that we presented at the Radium Society actually did show that radiotherapy, at least with extended follow-up, may increase the risk of mortality. But again, that's something that may need to be done in trials upcoming. But when we move to locally advanced disease, clearly, regional lymph nodes are at risk, and we from one standpoint can use, if it can be safely done, to decrease dose to the parotid by using IMRT. So what are the concerns with IMRT? And I'll try and break it up into general as well as larynx specific. But one of the problems that we face with IMRT, the cuter we get with our techniques, is we don't want to be too cute that we miss the tumor. So the risk of marginal failures. In addition, we have to also deal with low doses of radiation. Because we're coming in from lots of different angles, we can increase morbidity by just hitting areas that weren't hit before, especially in the era of doing concurrent chemotherapy. Otherwise, you also have to deal with higher doses of radiation that are generated to try and get these very rapid fall-offs in the dose that we see with IMRT, as well as problems we face with weight loss and tumor shrinkage when we're doing these fancy techniques. I'll go through some examples of that. So this is actually a recent article that was published from the group at Memorial Sloan Kettering that talked about that there was a potential that there was a new pattern of failure of patients with locally advanced larynx cancer treated in the IMRT era. And one of the problems with this, and again, one of the things that I look at this when I see this problem is, was this really a new pattern of spread, or is this a marginal failure? So one of the things that that was described in the editorial of this by Paul Harari was saying that maybe we shouldn't try and treat tumors so close to the parotid, and maybe these are most likely a marginal failure as opposed to a new pattern of failure. And again, this is something that I adopted from my teaching from Dr. Mendenhall and Dr. Amder when we first started doing the IMRT, is that patients with ipsilateral nodal involvement, you don't try and spare the parotid gland, you only spare the contralateral gland when there's no nodal involvement to make sure that you cover your disease adequately. Now, other issues that we deal with is regards to radiation be spread around. This is actually a patient when I was a resident at Florida, was treated with carboplatin and Taxol, and actually it got into about 30 gray when the patient required a treatment break because of this mucositis and the oral cavity, which again for an oropharynx cancer wouldn't have generally gotten it before. In addition, this is another case where with IMRT, if you don't contour everything, this is actually some data from actually another resident from Florida, but who was out in practice when he did this, that showed if you decrease the dose to the dorsophasal complex, that you can, or if you don't contour that area, that you can have an increased risk of nausea and vomiting because of higher doses to that complex in the brainstem. And now looking at some of the hotspots in radiation, this is kind of a general plan where you see a very conformal prescription to the target volume, which you kind of see just inside of that area, with a lower isodose line that is going at a much lower dose to treat all the regional lymph nodes that goes around. And at the same time, you see these areas of 8 and 10% hotter, which are outlined in the red, right around the edges of this area. And this potentially can be a problem. It can potentially cause increased side effects in the short term with ulcerations in the mouth, or as a case that I've stole from Dr. Sanguinetti, from this patient that was put on the RTOG study that actually developed an area of osteoradionecrosis in an area of a hot spot in the bone. But these are areas that you have to be very careful with when you're treating or looking at patients or treating patients with IMRT, to make sure you know where all your hot spots are, and try and one is to try and make those areas very small, but to be careful of where they are. In addition, this is more data in regards to just looking at what anatomical changes that people experience. This is actually a patient that presented with a large N3 disease in the neck that had basically about 45-pound weight loss and a significant decrease in the size of his disease. And when we did the dosimetry and went through the recalculations of this patient's plan, we were concerned about what could be going on. And clearly we saw underdosing of the target volume using this technique, as well as overdosing some of the critical structures. So one of the issues that we have to get into is, do we need to replan patients if they have a significant amount of weight loss and significant amount of tumor shrinkage? So when we look at concerns of IMRT specifically with larynx, there are other issues we have to deal with. Now, looking at some of the cases we described before in the T4 lesions, so they had tumors that were close to the skin, you have to be very careful with IMRT about risks of overdosing and underdosing at the skin, because the dose algorithms with IMRT are not very accurate close to the skin. So you have to do things at the time of your planning exercise to make sure you can get your dose up to the levels that you want it to. In addition, you also have to worry about air-tissue interface, as well as with the potential of risking underdosing of the tumor skin or a tumor at the surface. Probably more of an issue, although this hasn't been shown clinically, is that larynx movement during radiotherapy. And is this a problem with potentially underdosing just because you're moving a tumor in and out of a modulated field of radiation? So this is just an example of a patient actually that we treated after a partial laryngectomy that had multiple node involvement. And one of the things you have to do is, in order for treating things closer to the skin, you have to put something to make sure the dose is at the skin surface to get the dose higher. So we basically have to put a tissue equivalent bolus at the level of the skin to make sure the dose is adequate at that area. In addition, not to mention in patients treated in a post-op setting, that the target volumes are a lot more difficult to discern. So let's go into some of the clinical data. Now, when we look at the clinical data with IMRT, there's not a lot of clinical data out there. The largest series actually comes from Memorial Sloan Kettering that recently published this result, and there's really only two data sets that look only at larynx and hypopharynx cancers. And this is actually a group of patients who treated at Memorial that all got treated with concurrent chemotherapy with IMRT, treated slightly at a hypofractionated schedule at 70 gray and 33 treatments. And looking at this data set, it's again a typical locally advanced case that 3/4 had T3, T4 disease, 2/3 actually had larynx cancers, and 70% had stage 4 disease. And again, this was basically 30 patients. And looking at their outcomes with a median follow-up of about 2 years, their outcomes seem to be pretty good. Local control rates of 86%, in comparison to the RTOG study is a little bit higher, although clearly, it's a single institution retrospective series and everything else that goes that way. As well as the laryngectomy-free survival rate is also very high at 90%. And one of the things that we see is, all these patients have good outcomes, but again, there is, when we treat patients very aggressively with IMRT, especially for these large fields, we still have problems with feeding tube dependency. And actually, you can see with the patients with the larynx cancer is about a 15% 2-year risk of needing a feeding tube with this approach. So, from a quality of life standpoint, it may not be the best approach, but it is something that we have to be able to figure out, trying to make this better. And that's hopefully other things that we can do with IMRT. In addition, based on this other study that was published, which I didn't put a lot in there, the study from Zurich, you can actually see that the higher dose per fraction also, because they actually showed that the higher dose per fraction, or using a more of a hypofractionated approach, increased their risk of complications and feeding tube dependency with that approach. So where do we go from here? I was going to go through just a couple areas of what we can do. This is actually one thing that potentially can be done to try and improve control rates, although looking at that last data set, maybe we don't need to improve control rates. But, we can, this is actually a phase 1 looking at dose escalation using this fancier approach of treating people, again, with actually this much more hypofractionated approach, but at least based on this small data set, hypofractionated showed better complete response rate, although it also was associated with more mucositis, but no late complications based on the outcomes at this point from this study. And other approaches, and again, this is data that it's been from Netherlands as well as from Michigan, that potentially what we need to start looking at is different ways of predicting why people develop feeding tube dependency, and trying to use IMRT to try and decrease doses of certain structures if it's possible. Certainly what the parameters that have been set up by Dr. Eisbrook in regards to trying to decrease dose to the constrictor muscles and the supraglottic larynx is probably not possible for larynx cancers, but again, this is something that we need to look at in this population. In addition, one other thing that potentially can be done is, we can start using other more sophisticated imaging studies to try and decide on where we can dose paint. About this is actually using F-metronidazole to try and look at hypoxia, and potentially if you're can find areas of radioresistance, maybe you can do different things about escalating the dose, or as in this study showed from Peter McCowan actually used the hypoxic cell sensitizer to improve outcomes for patients that had hypoxic based on these PET scans. In addition, one other point is to try and come up with different approaches of doing real-time dose calculations for patients to see when it is important to actually replan their treatment plan. And this is stuff that we have ongoing that we're trying to work on to try and come up with doing these things on a real-time schedule, but not ready for prime time. As well as, again, going back to Dr. Mendenhall's data in regards to volume and patient selection. Again, the most important thing is selecting these patients well and trying to figure out which patients we can treat well and not cause increasing complications, and trying to figure out who we can avoid certain toxicities, or maybe avoid certain systemic therapies. Maybe we can start thinking about doing different cytotoxics. As, maybe these group of patients aren't at risk for distant disease, and all we need to do is improve local control. Maybe we can use targeted agents for certain subgroups of patients, as opposed to treating everybody with a locally advanced approach, and not figuring out who the intermediate risk people are. So thank you for your attention, and I hope you got out of this as much as my kid did. Thank you.
Thank you very much, Dr. Feigenberg. The next speaker I'd like to introduce is Dr. Khoury, speaking about chemotherapy for laryngeal cancer, the consensus and controversy. He's an oncologist from the Winship Cancer Institute in Atlanta, Georgia. Thank you.
Thank you very much. And when your Vice Dean for Faculty is in charge of the AAMC Conflict of Interest Committee, you get real specific with your conflict of interest. So I'm a consultant for Sanofi Aventis, have been for years. As you can see, we've diversified our funding for peer-reviewed fund over the last 15 years, but this is about 6% of my total funding, so hopefully you can trust me to give you a fairly controversial talk. My opinions on approaches to the treatment of larynx cancer are my own, and even though we like to think they're evidence-based, I'm sure they're controversial. So let's start with an evidence-based approach to chemotherapy in larynx cancer. I think we can agree that laryngeal cancers, as head and neck tumors go, are among the more chemosensitive. The VA larynx study really was a landmark study. That term is overused, but I think clearly this study established that induction chemotherapy could be given as an organ preservation approach, and if patients were carefully monitored, even the non-responders' chances of long-term survival were not hurt. There are better induction regimens than others. If you go to any session in that meeting, you'll know what they are, but I'll touch on them briefly. Concomitant chemoradiotherapy and induction chemotherapy are both viable organ-preserving approaches, as is partial laryngeal surgery in certain limited settings. And molecular determinants of chemo and radiosensitivity are still experimental. We're a long way behind breast cancer and even lung cancer in knowing who's going to do better and who's going to do worse. So let's start with induction chemotherapy. First of all, this is probably an underappreciated study by Dr. Domenge, but this was really the first study that showed that induction chemotherapy can improve survival. Published in the British Journal of Cancer, patients were randomized to cisplatin and 5-FU versus followed by surgery and/or radiotherapy versus surgery. This was a study in oropharyngeal cancer, and in fact, this study showed an advantage in overall survival. It's very rarely quoted, but it's there. So this really was the first study to show that adding induction chemotherapy to local therapy makes a difference. And we could have a 3-hour debate and everyone could go home unhappy as to concurrent or induction. What I'm going to try to make the point over the next 15 or 20 minutes is that both approaches are viable, and we really should start to move along in figuring out who should be arranged for which approach. So what are the strengths of both approaches? And each has strengths and weaknesses. In terms of concurrent chemoradiotherapy, the pros: improved local regional intensity, shortened treatment time, efficacy in unresectable disease, efficacy in organ preservation, and effective postoperative therapy. It has a long list of cons, as does induction. Local toxicities increased. The treatments that we used to get away with radiation alone are significantly more toxic when we add chemotherapy. There is some mortality that we can never quite determine what it's from. There's increased systemic toxicity. There may be induction of systemic resistance, and as of this year, we are still arguing as to what the standard approach should be. Induction has a list of pros and cons. No question it gives us high-dose systemic exposure. It can, in the proper patient, present them to the radiation oncologist or surgeon with improved nutrition and performance status, reduce the tumor volume, and potentially better prepare for definitive radiotherapy, potentially improving planning for IMRT. A lot of cons as well. Systemic toxicity is significantly worse as opposed to concurrent. Survival improvement, as far as we can tell, may be site and stage related. We're not sure. There's increased duration of therapy. There may be a change in tumor biology. There's no demonstrated improvement in local regional dose intensity. And until recently, platinum-based platinum 5-FU was the only effective chemotherapy regimen. That was until a short while ago. So let's look at the study that was just mentioned by both of the previous presenters, RTOG 9111, that really equalized between a number of different approaches. And remember here that the experimental arm really was radiotherapy, even though platinum and 5-FU induction followed by radiation had been shown to be a reasonable approach by the VA larynx. The real experimental arm here is platinum given concurrently with radiotherapy. This was published in the New England Journal by Arlene Forestier and her co-investigators. And this is the updated data from 2 years ago at ASCO, basically showing that larynx preservation is best. And the comparisons, remember, are with radiotherapy alone in the concurrent arm. But really, local regional failure, both the induction and the concurrent arm are better than radiation. Overall survival, only really minor differences that we can tell, but disease-free survival equally better in both induction and concurrent. So I would say, based on the largest trial of larynx cancer, both of these approaches remain very viable approaches in 2008. Now, I'm going to show some data that we took a while to accumulate at MD Anderson. This was a very, very specific trial that we designed with Ann Gillenwater and Ed Diaz some time ago. The manuscript has been written up and submitted by Chris Holsinger, who analyzed the data. We gave an induction chemotherapy regimen for 3 cycles based on the work by Olivier Lacouré, and then we got serial biopsies to see whether they had a CR, in which case patients had continuation of chemotherapy and very, very careful observation, a partial response, or no response, in which case they went to surgery with or without radiation. So this was always intended as a pilot study. It's a small study of 31 patients. The regimen was designed by Dong Shin and Scott Lipman and Steve Benner. It's paclitaxel, cisplatin, and ifosfamide. You don't see it very much anymore. It's called TIP. And it was a small patient population, mostly male, good performance status, and as you can tell, supraglottic larynx mostly, but a fairly broad distribution of primary laryngeal tumors. Now, as you can see, the vast majority were intermediate stage larynx, although some T4s were allowed on. No patients with disease that was beyond N1 disease were allowed on the study. And this is the patient population, the majority being stage 2 or 3. Now, laryngeal preservation was quite good at around 80%. We now have a median follow-up of a little over 5 years, and we did not hurt overall survival in this study. Now, recurrence-free survival was quite good as well. So this is a very small pilot study in which we were able to show that in patients who had a complete pathologic response, who were maintained on chemotherapy, about a third of these patients total, we were able to watch them, and their risk of recurrence, if they had a pathologic CR after 3 to 4 cycles, was extraordinarily low. All this study really shows is it sets the table at a single center of excellence for broader experimentation. This study should not be done in the community. It needs to be done with a series of outstanding sites where they look at this and see what this means, but should never be done again without obtaining preliminary tissue to look at the molecular phenotypes of the individuals who are treated. So adverse events were very tolerable, and here's a patient with a very dramatic response, as almost all the patients did, with intermediate stage larynx. Chemotherapy as an induction can be a very impressive modality. Whether it's a very effective modality and changes the subsequent therapy, I'm not in a position to answer, but I think this is certainly a provocative trial. Now, what about TPF versus PF induction chemotherapy? I'm going to show you some data that supports the idea of induction chemotherapy for an organ preservation approach, and then show you that clearly by now TPF is clearly entrenched as the best induction chemotherapy, if one does believe in induction chemotherapy. So here's a trial from Calais et al. Presented 2 years ago at the American Society of Clinical Oncology, in which they took patients with resectable locally advanced larynx or hypopharynx cancer, and they randomized them to either platinum 5-FU or docetaxel platinum 5-FU induction chemotherapy for up to 3 cycles, followed by radiation with or without surgery for the non-responders. And what they saw in the study, and the primary endpoint is larynx preservation, is a significant improvement in larynx preservation on the TPF arm. The study wasn't powered for survival, but at the last snapshot there was a separation of curves, but this is not yet statistically significant, and we await updated data. Small study of 220 patients, nonetheless provocative, and sets the table for developing induction chemotherapy, again, for organ preservation with surgery. And here's that data again in terms of disease-free survival, where it's not yet significant. Now, when you use an induction approach in this patient population, obviously toxicity is a concern. We certainly know that platinum 5-FU is a toxic approach. Was TPF more toxic? And the basic answer is not really. It added to neutropenia, it added slightly to neutropenic fever, and it certainly gave people a significant shave. But in terms of severe mucositis, because you reduce the dose of 5-FU, it's less than half of the mucositis produced with PF. The anemia is no more significant, and the thrombocytopenia is less. So on to the 2 studies for which the TPF induction regimen was approved by the FDA. Here's the first study in unresectable squamous cell head and neck cancer that's non-metastatic. Virtually all of these patients are stage 4. This was published last fall by Jan Vermoken and collaborators from the EORTC in the New England Journal. Patients with oral cavity, oropharynx, and hypopharynx, and most importantly for this discussion, laryngeal cancers were involved. 360 patients or so were accrued. The study randomized patients to 4 cycles of TPF versus PF, followed by a neck dissection, followed by definitive radiotherapy. So that, at least in the United States, would be a little bit of fairly controversial to go ahead with the neck dissection before the definitive local therapy. Nonetheless, their progression-free survival clearly favored TPF with a risk reduction of 28% in terms of the hazard ratio, and overall survival was also better at 18 versus 14 months. So this represents further progress and sets the table for further debate on the induction chemotherapy story. So in terms of toxicity, again, with the reduction in the doses of 5-FU and platinum, you can see while neutropenia again is higher, infection is not significantly so. Anemia is a little lower. Thrombocytopenia and stomatitis are significantly less. Now, what about the U.S. approach of induction chemotherapy followed by concomitant chemoradiotherapy? This was a study led by Marshall Posner based on a number of trials from his group. 539 patients were randomized with advanced stage disease, including laryngeal cancer, to either cisplatin and 5-FU or a more robust dose of cisplatin, 5-FU, and docetaxel than the previous study. Here, as you can see, they're using 100 per meter squared of platinum and a gram per meter squared of 5-FU, albeit for 4 days, followed by radiotherapy with carboplatin with surgery again for the neck or the non-responders. Now here you had a dramatic difference in overall survival. That was the primary endpoint of this study. You could see the median overall survival at the time not reached when this study was first reported, highly significant p-value and almost doubling of median survival, as well as of progression-free survival. So since the platinum here and the 5-FU were more intensive than in the European TPF, you had a more significant difference in neutropenia and a more modest difference in stomatitis as opposed to the other studies. Nonetheless, nausea was the same. Febrile neutropenia was higher for TPF. Docetaxel does induce neutropenia, and neutropenic infection slightly higher, 12% versus 9%. So there are other trials. Platinum 5-FU and paclitaxel was published by Roberto Hitt and JCO. They randomized 380 patients to platinum and 5-FU versus a combination of paclitaxel, cisplatin, and 5-FU. These patients were then subjected to radiotherapy concomitant with cisplatin, followed potentially by surgery. So these patients really got a fairly robust dose of platinum, 100 per meter squared for up to 3 cycles, then 100 per meter squared concomitant with radiation for 3 weeks. And this study showed an improvement in response rate, particularly complete response rate for the paclitaxel addition, but time to treatment failure is better, but median survival did not quite reach statistical significance. So while this data is intriguing, this regimen is not moving forward. Again, it's worthwhile to look at toxicity, mucositis less, because here you do reduce the doses of 5-FU and platinum. Neutropenia is more, and then fatigue is about the same. Nausea, vomiting less, since you're reducing the dose of 5-FU. So I want to close by showing you the complexity of choices that we have in head and neck cancer, and we treat a larynx case by presenting a case. Usually we present a case at the beginning, but I'm going to end with a case to show you that as opposed to where we were 5 years ago, we have a number of choices, and I believe many of them to be viable. So a 56-year-old gentleman presents with hoarseness, otalgia of 3 months duration, who not atypically is treated with antibiotics before he's referred to an ENT, a 40-pack year, smoking history, quit 3 years ago. I don't have many patients who admit to drinking wine daily. The phrase I most frequently hear is wine on the weekends, so we added that. A myocardial infarction with a stent 3 years ago, and mild hypertension, which is well controlled. The exam shows a tumor of the left supraglottic larynx, a paralyzed left vocal cord, and a 2.5 centimeter left level 2 lymph node, T3N1 stage 3. The patient has a resectable stage 3 larynx cancer, good PS, and minimal comorbidities. And which treatment option would you recommend? Total laryngectomy, certainly not completely unreasonable, or an organ preservation approach, which I believe would be the majority vote here. Chemoradiotherapy, how many people would vote for, in the audience, for total laryngectomy? Raise your hands. How about chemoradiotherapy given concomitantly? Okay. Induction chemotherapy followed by radiation. A few, but less. Sequential therapy, induction chemotherapy followed by chemoradiotherapy. So certainly more than induction chemotherapy, but less than concomitant. How about radiotherapy with concurrent cetuximab? Probably a little less data in the larynx. Haven't really gone over that today. So my feeling is that total laryngectomy remains a reasonable option. The other options offer organ preservation and equivalent or perhaps even better survival. I think bolus cisplatin-based chemoradiotherapy and PF-based induction chemotherapy are equivalent in terms of 5-year laryngectomy, as Dr. Forestier and her co-investigators showed, and significantly better than radiotherapy alone. There's a suggestion that PF-based induction chemotherapy can improve survival compared with chemoradiotherapy. I don't completely buy that, but I think if you're going to use an induction approach, I think TPF-based induction chemotherapy is better for organ preservation than PF-based induction chemotherapy, and better for survival and probably less toxic. So I'm going to end there and acknowledge my many collaborators over my career at MD Anderson and currently at Emory, including a number of people, including Dong Shin and Amy Chen, with whom I've collaborated at both institutions, and mentioning that without the support of my colleagues, particularly in head and neck surgery, particularly Helmuth Gepfert in medical oncology, particularly Ki Hong, radiology. I've been lucky with both Larry Ginsberg and Pat Hudgens, and radiation oncology, Adam Garden, Jonathan Beitler, Bill Morrison, particularly in Fadi Gira. And I'll stop there. Thank you very much.
Wow. I'd just like to thank so far the speakers speaking about locally advanced larynx cancer, and we're just going to change direction a little bit now. I'd like to introduce Dr. Stephen Zeitels. He's a professor of laryngeal surgery and the director of the Center for Laryngeal Surgery and Voice Preservation at MGH in Boston. And he's going to change a little and talk about an interesting technique he's doing of laser photoangiolysis for glottic cancer. Thank you.
Thanks. There are a few extra videos, so I'm going to do it from the computer. I appreciate the opportunity to share this with you. It is a little bit different than what you've seen, and it is not exactly on topic for advanced laryngeal cancer, but I think you'll find it interesting. You can see the potential applications for something like this. Can you switch me over in the back? So what we're going to be doing here is looking at a completely different approach, and the surgeons in the audience would have likely received this as a supplement to the annals this week. It was mailed out. So hopefully, I think we're pretty good. We're good? We're good. Great. Thank you very much. So anyway, this is a bit of a different approach. We came at this gradually. I welcome the controversy that this is going to bring, because to some degree we have actually stopped resecting early glottic cancer for a number of reasons, and are taking a somewhat hybrid approach that probably is some of a mixture between using radiation, albeit non-ionizing radiation, and surgery. The disclosures here, most of the work for this has actually been funded by nonprofits. We have received no funding of any kind, either personally or for the research from any laser company. I do have a interest in a laryngoscope company. The MGH group is interesting because it started just after the American Civil War, and it was the second place in America with partnering with Harvard to actually have a laryngeal program. It existed till 1925, and then many of you know Mosher's name. Mosher moved it to the Mass Eye and Ear. Our group moved over to the Mass General about 4 years ago. Knight, who you see here, was the gentleman who was the first professor at Harvard, was actually the pulmonologist at the time. And you can see we're a very different group today. My coworkers, as you see here, involve folks at MIT and the Wellman Labs, which is where a lot of this work evolved from. And my partner, Bob Hillman, has been with me for 15 years as one of the probably really fine voice scientists in America. So what we're talking about here is because this is a little bit of a primer in voice, not everybody in the audience looks at vocal cords all the time. If you have a deficit in vocal function in some form or another, you have aerodynamic incompetence or lack of mucosal pliability, some combination thereof, we can close this valve. We have no way to restore pliability. If you hear hoarseness, it's because there's been some deficit in one or both of these factors. When you think of tumor, very often you actually don't have air leakage, yet you hear the air because that softness of the membrane is gone and replaced by the tumor mass. The softer a surface is, the more efficient it translates air from your trachea into an acoustic signal. What the holy grail for the field is likely to make this layer, and I'll show you an example of that layer because I think we're going to retroactively be able to go back and treat a lot of cancer patients and restore their voices. So the question is, for a long time, surgery has been done for probably about 140 years for early glottic cancer. And which is it? And I hope you'll see that there may be as benefits of both, and maybe that this approach really combines some of the assets of both. For the historians, this is, as best I can tell, the first surgeon to become a laryngologist and the first person to cure larynx cancer. This is Jacob Salas Cohn right after the Civil War. Oldest photograph I've seen of somebody in an actual photograph examining a patient. This is about 1866. He did a hemilaryngectomy on a patient with glottic cancer who was a professor's son at Penn. This is Frankel. Frankel's the first person to endoscopically resect glottic cancer. It was mirror-guided. It was 1886. It was a piecemeal resection similar to what some of the people do today. This is Clyde Lynch. After the era of direct laryngoscopy, he actually publishes the first series, and this is about 1920, where he actually resects it through his Lynch speculum, which was essentially like Killian's, and he actually resected it. Yes, that's right. They're telling me to hook in the sound when we get to it so you can hear the voices. Thank you. That's all right. So this is the laryngoscope. Many of the surgeons who do wide field resections of glottis use this now. This is why I had to do the disclosure. We designed and patented this thing a decade ago, and it's become our workhorse for the glottis. What you see is almost all laryngoscopes are circles and ovals. This was designed to be the contours of the inner thyroid lamina, so you could do a complete anterior commissure resection and the posterior paraglottic space. Also, for the era of bringing in fiber-based lasers, it's slotted proximally so that you can get the angulation yet not widen the laryngoscope, so you would have the greatest inner diameter for the narrowest outer diameter, which gets a bigger scope in. The precision of an endoscopic glottic cancer resection is unquestionably what your exposure is. So through the 90s, we worked on trying to narrow margins, yet not create failures. And we effectively were able to do this, taking further what Hirano had done in the 80s. And what the goal here was to resect, not have 1 millimeter margins at the perimeter and then take 5 millimeter margins at the depth of the tumor. There was no great imaging, so what we had to use was, for the most part, indirect assessments in stroboscopy varying pitch to determine where there had been depth of invasion. And then what we also learned, since there was the evolution of Ishiki's work in laryngoplasty, is that when we had aerodynamic incompetence, we could actually reconstruct the paraglottic space, and this became pretty simple to do. So what you had is a hybrid, again, of advancing microsurgical techniques with laryngeal reconstructive techniques. What we learned is with unilateral disease, we could give almost anyone a normal conversational level voice. What this meant was they didn't necessarily have maximal range tests for frequency, for loudness, but if you were speaking to them, you would barely know that they had surgery. The key problem that we always had was, how are we going to do this for people with bilateral disease? So to pay homage to what we really kind of put together here, you're looking at, this is Jaakko. This is the first man to cut any tumor out with microsurgical instruments, and then, of course, the laser as well, and he brought it to the Boston University group. Polanyi actually designed the first CO2 laser that was used to resect tissue at American Optical, and Dr. Folkman. You know, for me, it was actually a really sort of interesting and important experience. I met with him about 12 weeks before he died to show him these cases. And he gave me a whole series of suggestions, which I hope to share with you folks over the next couple of years. And now not only how to look at non-ionizing radiation, but some of the drugs that have been discussed and how to use them locally within the tumors. So interestingly enough, if you go back to a paper very few people have seen, this comes out in 1966 as part of an AMA presentation from Biacco and Kleinsasser on microlaryngology and microlaryngoscopy. And Kleinsasser was a pathologist. He's drawing angiogenesis here. When you have dysplasia, you're going to obscure the arborization of the vessels. When you ultimately start to get the neovascularization, this is the pattern. And then 5 years later, Folkman formally describes it. So this was an older glottic cancer resection that I did, and you can see the arborizing vessels then branching out just the way these folks had all described. So when we think of it, many of the things we work with in the glottis, be it benign or malignant, are angiogenic. This is a singer who's been doing a lot of rock and roll. This is papillomatosis, which for us, as we begin to look at some of these issues, is even better than a cancer model because it recurs faster. So when we look at what goes on, this is a great benign tumor model for understanding what goes on in angiogenesis. And this is dysplasia. So we had decided to select a group of lasers that would go for the microcirculation that had been designed initially for babies' vascular malformations. And essentially, there's a guy, Anderson, who we work with now, who is a laser physics person by trade. And he said, you know, what you need is a laser that's going to treat the sort of like an infant's skin, because pliability is what's key when you're preserving that. And that's what goes on with vocal folds to vibrate. So then if you advance this, we treated dysplasia for the better part of about 6 years and then began to start looking at very early glottic cancer. And again, if you look at this T1 glottic cancer, you can see the angiogenesis. It's very clear when you look under a microscope. So Anderson describes these before the lasers exist, actually. And what happens is, and Anderson came up with the concept of pulsing light at the 2 wavelengths of absorbance of hemoglobin, which are yellow and green. And then we decided that this was really like dealing with early glottic cancer because you had these microcirculatory problems. So the best model to teach this for the surgeons is the Chick chorioallantoic membrane, because this microcirculation is very similar to what it's like dealing with the blood vessels in the subepithelial tissue of a vocal fold. So the yellow light is how we started, but it ruptured a lot. Then we moved on to a pulsed green light, and the KTP has pretty much replaced the PDL. It's a much more stable laser, easy to use, smaller fibers, and you can see that because you can extend the pulse width, you rarely get vessel wall rupture. So we can do many of these procedures almost bloodlessly and also not burn the tissue underneath. The difference with this approach than a CO2 is the CO2 or a thulium is actually burning the tissue underneath, and you can't see what the normal looks like. So to give you an idea of the precision of this, this is actually just a singer who was hemorrhaged. Let's get the sound going. So you can see what's happened. And this person has sung more large-scale rock shows than anyone in history, probably. And now you're going to see how precisely you can deal with the aberrant vessels and then understand why it works with cancer. So this vessel was blowing, and he didn't have a lot of soft tissue left to sing with. So you're seeing just some saline and adrenaline. And the reason I show you this is in this setting, we can actually involute the blood supply without even disturbing the epithelium over it. That's how precise this class of laser is. What you're depending on in a tumor is that the tumor itself has concentrated blood, so that's exactly where this laser is going for, and it's not actually going to hurt the soft tissue under it. So what you take home from this, the tumor's denser blood supply, just the way Folkman described, is drawing the light. The tissue under it, just the same way the epithelium over this vessel isn't being destroyed, is not substantially destroyed. For those who don't know, this is the singer from Aerosmith. So with that, we embarked past the dysplasia patients. So we had a good 6-year history of using this with dysplasia and papillomatosis, and remarkably, by involuting the subepithelial microcirculation of dysplasia, it would normalize. That also allowed us to do the first office-based laser procedure. So in 2001, we realized we didn't necessarily have to take papilloma patients and dysplasia patients to the OR. We could just involute the blood supply in the office with a flexible scope. So what's some of the, at least the reasonable oncologic logic here, so to speak? Early glottic cancer rarely metastasizes, so this is not a scenario where intercurrent disease is a problem. In fact, if I biopsy someone on January 1st, I'll be happy and fortunate if they're beginning radiotherapy in 2 or 3 weeks, and that takes 6 weeks. So they're not done with their treatment for 6 to 8 weeks anyway. We're suggesting that in the right patients, you can treat them up front and that you don't even have to depend upon getting all of it out in the first shot. You'll come back at 6 weeks. This disease doesn't drop deep. It's right at the surface, and then you complete your treatment. It's especially important in maintaining the architecture of the anterior glottal commissure, and that's how you're maintaining the voices. So what we're really saying here is that there's a denser blood supply in the microcirculation of these tumors, and it's extremely easy for any surgeon who's done microsurgery of the vocal folds to do these operations. You start with small ones, you move on to big ones. You see it. As long as you can expose the patient, it's very, very easy to do. And it's not that we devalue radiotherapy, it's that it's too important, that this is a 95% cure rate doing this in the operating room in a couple of hours, and that patient can go on to have radiotherapy at any time in their life. So the manuscript which arrived was a very early pilot study. Obviously, there needs to be more studies. People have to try it, but it was very encouraging. These people were T2 not because of impaired mobility. They were extension into another part of the larynx, subglottis, supraglottis. We're now doing impaired mobility. One T4 just went down into the trachea, and depending upon what staging method you use. 12 of the 23 were bilateral. This is where it's made its biggest effect for us, because we now can, usually when somebody has bilateral disease, there's a dominance, and we can now treat one side, then the other side, and typically, unfortunately, with radiotherapy, you have to treat, at least for the moment, until IMRT comes in, both sides. I think the whole equation gets re-looked at when you can split the sides, and maybe that will happen one day. But for the moment, you're not treating the non-cancerous tissue, and that can fibrose over time, and usually, to some degree, the saccule is treated, and vocal folds require much higher pressures to drive into vibration if they are dry. And for those who don't know it, the saccule is like the oil can of the larynx. If you knock it out, they're going to be drier, way higher subglottal pressures to drive them into vibration. So what we're looking at here is that all of our patients now are treated with a KTP. The mean is about 32 months. The longest patients are out over 5 years. Interestingly, as we made the presentation at the combined spring meetings, we have now done 30 in the last 3 months. Docs are actually flying with their patients, and this is not a particularly hard technique, which I'll show you examples. This is a woman, and this is how we started doing a hybrid. This is a woman with she's nearly aphonic, extensive right-sided tumor, but it was pretty much filling the paraglottic space on the right. We split the tumor in half, did a conventional endoscopic resection, and involuted the blood supply on the contralateral left vocal fold. So this is what she sounded like.
My voice started getting hoarse in September. In October, I've been teaching very intensively with a hoarse voice.
So she was a management professor. This is what she had. So understand the physiology. This is not aerodynamic leakage. Nothing's oscillating. Tumor does not oscillate. She's just doing this because she can't vibrate. So the goal here was to do a conventional paraglottic space resection on the right, try to restore what vibration was restorable on the left, and see if we can get a voice out of her.
Deep breath.
So the tumor extends to her vocal process, goes around, and this was deep into the muscle. So this was a resection, and then used every strategy we had. We took fat from her abdomen and put it in. We used Gore-Tex, and we split her thyroid lamina to close the hole in the front and did this, what we call a thyroid lamina subluxation. What you're going to see is how she looked at the end of the resection, healed with epithelium, prior to paraglottic space reconstruction. So you'll see this vibrate, but she's still aerodynamically incompetent. So membrane is coming back now, but a big hole because there's no soft tissue here yet.
Breathe. Again.
So what's happening here is, in fact, that tumor wasn't down to the ligament and we could restore it. And these were the beginning cases. So this is how she looks after her paraglottic space has been reconstructed. Same quality voice, but she could, the minute she got louder, she could drive that into better vibration. In addition, she required much lower pressures to produce that voice, which helped her teaching dramatically. Breathe. Now to see her conversational voice, which she's not so different than many Israelis who talk a lot.
Yeah, after having 3 operations on my vocal cord, I guess what we do now is have another test to see how I progress.
So we very carefully analyzed the acoustics and aerodynamics of all these people. She's out over 5 years at this point. She's never had radiotherapy. She's never had chemo. This is an interesting gentleman who was actually from the Middle East that was referred by Dr. Steiner because he kept saying to him, my voice, my voice, my voice, and he was a lecturer in his company, and he was 50 years old.
Well, he explained to me the situation, and that he has, like this.
So you hear the aerodynamic leakage and the harshness.
To remove this tumor and to keep the voice.
So here's the tumor, above the anterior commissure, below the anterior commissure, extending to this side and out to the vocal process, if you saw the lights down. And you hear why he's leaking air. The tumor's acting like a polyp. This is what it looked like. So this was no subtle neoplasm, and it was socked into his anterior commissure. So what you're seeing here in a pulsed mode, wherever you see carbon, it's where there's more blood supply. We now will do this in a continuous wave to actually get through the tumor faster, because this is very, very methodical. But what you're seeing is the interface of the tumor to the normal tissue, and unlike an ablative laser, you're not leaving a horrible eschar because you've burned the soft tissue. In fact, it's done almost nothing, similar to that example with Tyler, to the tissues under it, so they heal relatively faster. And so what you get the opportunity to do is actually see. So if Steiner would approach that interface by looking in a transverse section, we're doing it from the inside out and then testing it. And again, very few people I've ever seen with this type of T1 or T2 disease has ever presented with metastasis, ever gone on to metastasis, and this becomes nothing more than a slightly longer polyp operation. Now you can see here, and this is what's so remarkable, this is the interface. You can see how normal it is. In any other laser we've ever used, we were not able to actually see the soft tissues underneath, so we knew where to stop. So this is how this man ends up. He's not great with the stroboscope. He learned. Now, there's clearly a difference. It was a right dominant tumor, but you see, in fact, I'm going to show you something unusual on his physiology, that he's closing. He's got a reasonably good vocal fold on one side. Breathe. Now, this is something a little unusual, probably no one has seen. This is ultra-high-speed photography from an extremely expensive military camera to film explosions. This is not stroboscopy. In a light environment like an explosion, this does 190,000 frames a second of color digital. This is about 8,000 frames a second. You'll see the asymmetry. So it's not at one frequency. You're seeing every bit of tissue, and this type of photography is teaching us how glottic cancer patients function after all kinds of procedures. And you can see the oscillation pattern that even with these asymmetries, he can entrain quite well. So to give you an idea what the future is, we've been working for a decade, and we will shortly have biomaterials. We're optimistic that by next year, we're going to have biomaterials to go subepithelial. We've been at this for a while. What you're seeing in this film, and these are the last couple of slides, is that this is an angiocath in an ex vivo model driven subepithelial, so this can't vibrate, sort of like that cancer patient just now. And this is an ex vivo mammalian model. You see, it can't oscillate because we've got a piece of plastic in it. And now we're going to inject the material under the epithelium here. This now becomes what we hope to be able to do is go back to any person who's hoarse and then restore their voice. Now you're going to see with that material which has been dyed blue that it's now oscillating and picking up the elastic properties of it. Because remember, we're trying to make this layer. And that's been the holy grail, because probably 95% of hoarseness that's untreatable is not aerodynamic incompetence, because we can close valve. We cannot restore pliability. The epithelium that grows assumes the viscoelastic properties of whatever's under it. And to understand how well you can sound without even having one side with the layer, this is how he finally turns out. Let's see here. Whoa, maybe not. Maybe not. He's jammed on us, probably on the last one. But suffice it to say, this gentleman, let's see, maybe. I probably won't get it. It'll take too much time. He has a completely normal conversational voice. So what we've learned is that you actually only need about 6 to 7 millimeters of this superficial lamina propria to have a normal voice. Thanks for your attention.
I'd like to thank the 4 speakers that we've had this afternoon. We do have 5 minutes or so. If people have some questions for any of the 4 speakers, I'm sure they'd be happy to come up here and answer anything. There are some microphones if people want to step up to the microphone to ask anything. Dazzled into silence. I'd like to thank Drs. Mendenhall, Feigenberg, Khoury and Zeitels for this afternoon's lecture. I hope you've enjoyed and learned something about treating cancer. Thank you.